Sure, absolutely.
Hey, how are you? Good to see you. Hey. So what's the game? Well, good morning, folks. My name is Alan Cockle. I direct health programs here at the Pew Charitable Trust, and it's my pleasure to welcome you here this morning and to serve as moderator for the first part of today's program. Pew is a nonprofit research and policy organization, and our health work touches on a wide range of issues. Our specialty drugs research initiative, the relevant one today, focuses on managing the high cost of new drugs and balancing the challenge of managing those costs against the need for access to innovative medicines. It's my pleasure to welcome you to a discussion of a proposed Medicare Part B demonstration project. This discussion and this proposed experiment comes at a time when the public and policymakers are very focused on the cost of prescription drugs. A Kaiser poll recently found that 72% of Americans say that drug costs are unreasonable. A recent ASPE analysis found that U.S. prescription drug spending hit $457 billion in 2015, or 17% of healthcare costs. ASPE also projects that drug spending will continue to rise by about 7% a year for the next several years, as it will as the share of total healthcare spending. In Medicare Part B specifically, drug spending reached $22 billion in 2015, which is double the amount spent in 2007. As I'm sure everyone in this room is aware, most drugs in Part B are infused or injectable drugs that are administered in doctors' offices or hospital outpatient departments generally, under a buy-and-bill system in which the provider purchases the drugs from the drug companies and bills Medicare after administering them to the patient. We'll add some detail to that picture as we go today, but suffice to say that this system adds a larger add-on payment to more expensive drugs. What we don't know is how changing the system might affect total expenditures, utilization of drugs, patient access, other consequences throughout the healthcare system. CMS announced about a month ago a proposed experiment in Part B to look at some changes, to study in a careful way some changes to this program, and we're pleased to have a distinguished panel here to discuss the proposal. Our key questions for the day are, does a Part B drug reimbursement experiment or demonstration make sense? And if so, what are the right interventions to test? And what can we say about the proposed experimental design to make sure that we get a robust result? We look forward to the discussion. So I'll introduce our keynote speaker in a moment, but just a couple of housekeeping notes. We've had tremendous interest today. We have about 120 people in this room and more watching live via webcast. And that includes some press, and we welcome you here. It's an open public meeting. If anyone plans to tweet the meeting today, we suggest the hashtag #PartBdemo. With that, let me turn it over to Dr. Patrick Conway from CMS. Dr. Conway, as I'm sure you know, is the Chief Medical Officer for CMS and the Principal Deputy Administrator for Innovation and Quality. He's also a practicing pediatrician. And he will walk us through what CMS is proposing, and he's agreed to take questions after his remarks, although he has a hard stop, we understand, at 9:45. So, Dr. Conway, thank you very much and welcome.
Thank you so much for having me here today. I do have a press call at 9:45, so left in a little before that. Apologize about the timing. It is actually a press call. It can be verified. Somebody was joking with me on the way in. I'd say a couple things about the Part B model, and I'll hit on some high-level points, and then, as was said, I will take questions and discussion. Number one, and this is important to note, this is a proposal to test changes in the Part B drug program. CMS is engaging. We had received input prior to this proposal, and now we're going through the most public and engaged process that we can, which is through our notice of proposal and comment rulemaking. We look forward, certainly today, but more importantly in the process of sending formal comments for people to comment on what they agree with in the proposal, what they don't agree with in the proposal, what needs to be adjusted, etc. And we will look at those comments closely and adjust as needed. It's also important to know, like all innovation center models, we can learn and adjust over time. I'll call out 3 principles, and then I'm going to call out just a couple high-level points about the model, and then talk briefly about some of the things we've heard publicly already. The first principle, access. So for us, access for medications to beneficiaries is the first principle of all the work that we do. This model, we believe as proposed, but we look forward to comments on this, will provide access to any medication that any beneficiary needs at any time. We think it incentivizes the right medication at the right time for beneficiaries. 2, related to access, doctors can and should prescribe any medicine that they think is the right choice for any beneficiary. I also should say I believe that doctors generally prescribe medicines that are best for patients. I'm a physician. I think most physicians make decisions based on patient interest. Interestingly, in one of the meetings we had, some comments concerned me at times on the opposite direction of this model. So we had a group that came in and said, I always want to give the right medicine to the right patient. This model, I'm worried that if for drug X, I would never give it to any patient because it might be unprofitable to me. One, that concerns me because I want doctors to give the right medicine to the right patient at all times. 2, if it's true that there's a class of medications or certain examples where this model would not cover the ability for doctors and physicians to prescribe a given medicine, we would want to know that, because access is a first principle for us in this model and the work that we do. The second principle is better outcomes for patients. Our work at CMS and at HHS is all focused on better outcomes for patients, learning what works, scaling successful models, and with the patient first and foremost, and the beneficiary in all our models. We think that this model allows a paradigm that would improve outcomes for patients. Specifically in the sections of the model that have been talked less about, but I'll talk a little bit more about in a minute. Aligning what's called phase 2 of the model, but it's really just different components, but aligning payment with outcomes in the medication space. So everything for course of therapy and paying for outcomes, to outcome-based pricing, to indication-specific pricing, to lower cost sharing for beneficiaries, for medicines that are high value. We think these are concepts that we've seen in the private market and we've seen elsewhere and seen the success of some of these value-based initiatives, and we think we should test how to best pay for outcomes in Medicare Part B as well. So this is an array of tools that we think will be beneficial in the long term. I should highlight here, we also acknowledge that many of these tools need further development and patient input. So we look forward to your comments on this, but we would have a public, open process where patients and consumers are the key people at the table to define and help us define what are outcomes that are most meaningful to patients and how do we structure this work so it is evidence-based and supports better outcomes for patients. The third principle is that we need to learn and adjust over time. So like all innovation center models, we think this is a learning process where we're making proposals, we'll adjust those proposals, and we'll continue to learn and adjust through engagement deeply with providers, with industry, with patient groups, with purchasers over time. At a high level in the model, just to give the content specifics, we have a proposal. It's geographic based. Because we thought that was the strongest design for this model, but we look forward for comments on that as well. There's a proposal that essentially has a component on ASP, average sales price changes, where one arm as proposed would be 2.5% plus a fixed fee in certain areas of the country, as opposed to the current ASP plus 6. Sequester is the same on both sides of the equation, so if sequester continues, it would continue on both sides. If it goes away, it would go away on both sides of the equation. This MedPAC had talked, and other policy experts, about changes such as these. So that's one component of the proposal. And this would be compared to areas that do not have that change. The other component is testing the value-based strategies. So the various strategies I named, and we identified that we think different strategies may be better for different classes of drugs. We would want to engage in a process with the public as we roll out the various value-based purchasing strategies and drugs. But as was alluded to, we think value-based, we want to pay for value in our health system, and we think drugs is no exception. And we want to learn how to do that well. I'll briefly name 4 things we've heard. Obviously, it's rulemaking, so I can't comment on what we will do, but things we've already heard publicly. So this is not disclosing new information, but to highlight some of the issues that have been outlined. One on geography. We've already heard from, in various public forums, people are questioning, what should be the scope of the model, and is it the right geographic scope? So we look forward to comments on that, including, it's always helpful if people are specific. If you have different suggestions around geography or scope, that's much more helpful. That's true across all these categories, by the way. 2, on the physician-clinician issues, especially small and rural independent practices as examples, small and or rural. We care deeply about independent physician practice and the ability for access to medications in various areas of the country. So once again, if there are specific examples of how this would limit access in any way in some of these settings, we would want to know about that, because access is a first principle. I would also highlight here that the current payment mechanism may have some unintended consequences. So please, compare it to the current status quo as well. So for a $10 medication today, an ASP plus 6 construct, we pay 60 cents. That actually may not cover, in many instances, the cost of providing that drug. So specific examples versus the status quo would be helpful. I should say we designed the ASP changes to be budget neutral in totality, meaning we took ASP plus 6 minus sequester, and we designed ASP plus 2.5 plus fixed fee plus sequester in a budget neutral way. If you look at the impact table, it actually shifts a very small amount of dollars towards physicians. But if there's other designs or changes or exceptions or processes that need to be put in place for example, smaller physician-led practices, we want to hear about that. We've heard about our oncology care model and the interaction with this model. I'd say we put in the proposed rule to include the oncology care model, but we specifically said an alternative considered would be to remove those practices because they're in a different test. And, we have to, if you include them, there's also evaluation aspects you have to think about. So, we look forward to people's comments on that. Lastly, and we thought we expressed this well in the proposal, but I've heard from some patient groups and that I want to say this clearly. Patient and consumer input into this model is critical. So we hear you, and we will deeply engage patient and consumer communities in this model, both in this period where we're looking at what should be finalized or not finalized or adjusted, and along the way. So the patient and consumer input, and I see some colleagues here that have talked about this for a long time, is critical. I've dealt with this as a physician, and there was another article in the press recently of patients and consumers struggling to get the drugs they need in our current system. So the question is, we want to solve for access, better health outcomes, and a sustainable system, and we think we can solve for all three, and we think that we need to test new ways to solve for all three. And our current system at times has access problems, doesn't always achieve the outcomes we want for patients, and so we're proposing a way that we think will achieve those better health outcomes, smarter spending, and healthier people for our nation. I was super quick, which is always dangerous because it means more time for questions and discussion, but it does mean I won't feel as bad about having to leave on time. But I really want to thank Pew for having me. The work that you do here is tremendous, and we value it. And want to thank all of you for taking the time to be here today, and look forward to the questions and discussion.
Let me ask the first question, Patrick. Thank you. The proposed experiment has two phases. Phase one is much more concrete than phase two at this stage. I'm not asking to predict where you'll go, but how much scope do you have to change the proposed intervention in phase one at this stage?
Yeah, we have the ability to change both, and I think it's fair to say the phase one changes had more written about, more MedPAC discussion, so we were able to be more specific in our proposals. The phase two, I and we are very excited about the potential. But you are right. We've basically proposed a set of tools and approaches and processes, and then there will be a lot of work to define over time, what is finalized obviously in the rule, but then also how do you roll that out in a very engaged, thoughtful way. And, our goal would be to do it in a very engaged, thoughtful way. I think you don't want to roll this out in a way that you have unintended negative consequences or those kind of issues that I alluded to we want to avoid. And I think we'll need people's help, both Pew and, researchers in this area, patients and consumer groups, to help us define, with that set of tools, what are the best approaches. Manufacturers, we've talked to a lot of manufacturers that are we have talked to manufacturers previous to this proposal that have come to us and said, we're interested in value-based purchasing in the drug arena. And so, how do you engage the diversity of stakeholders in this model so that it really can be a win for patients and also a win for various stakeholders in the system? Other questions or comments? Yeah, no, I have an official.
Hi, Patrick.
Yeah.
Tom
Hello,
Vallet
Tom.
with Discern Health. I'm interested in the potential unintended consequences that you mentioned, and particularly the kinds of measures that you might use in the short and longer term monitoring strategies and evaluation strategies. I've reviewed closely the proposed rule and looked for some specifics in that regard, and I didn't see as many as I have in some of the other proposals. We have some ideas about how to do that, which I'd love to talk to you about. But how much thought have you given in that regard? And how, between the proposed and final rule, how do you expect to develop your monitoring and evaluation strategy?
Yeah, it's a great question, Tom. So first, we'd be very open to yours and others' ideas. We have a couple ways we look at this. One is, for all models, including this one, we would have a monitoring strategy, which is usually using claims data to monitor for both health outcomes that you can detect in claims data, plus access issues. So we actually have learned from the DME area and competitive bidding how to put processes in place to monitor for access. We can get data that is literally days old and be analyzing. So much more sophisticated monitoring system now than 5 years ago when I started at CMS. And we would deploy that monitoring system and continue to improve it over time. Two, on the evaluation, we have a high-level design that is, intervention groups and control groups, and it's actually a 2x2 matrix. Then we would have a set of measures, both quality, and we always lead with quality, and cost across those various arms. The beauty, we think one of the advantages of this model, and that we've done in some other instances, and I'll name a few, we have the ability to use quality metrics that exist now. We also, in innovation center models, have shown our willingness to test quality measures that may not be fully vetted or in existence now, including patient-reported outcome measures. So I think that's a huge opportunity in this model. So our joint replacement model, we are testing, implementing a patient-reported outcome measure at scale in joint replacement, which the model gave us the sort of infrastructure and capacity to do. You could imagine, and I don't know what classes, et cetera, because that's what we're laying out that we will be looking at, but I think it gives the ability, for example, to have patient-reported outcome measures, measures around functional status and quality of life, measures that, in our current programs we don't always have. So I think it's a real opportunity to test those measures in an innovation center construct, an innovation construct, and then for ones that work, you can then bring them into our core programs, which for the nation, my father passed away from cancer. As cancer touches almost everyone in some way. The quality measures around many of these specialty areas in the U.S. are not always what's meaningful to patients. So how do you test new measures that are meaningful to patients in these type of models, and then, when applicable, bring them into core payment programs? Sorry, I'll try to be brief with my answers. I'll just keep following the mic.
Good morning, Patrick. Thank you for your leadership on this and many other areas. John Rother with the Campaign for Sustainable Prescription Drug Prices. You mentioned almost in passing that doctors might receive a net increase as a result of this proposal. I think that's the one fact that's probably not been much in the public arena. Could you explain a little further?
Yeah, so thank you for the question, John. And I should probably, in the future, not mention it just in passing. But, so when we're thinking about the design here, we purposely tried to design it budget neutral in total. So there's the ASP plus a fixed fee, plus in the intervention arm, the 2.5%. Turns out that in aggregate, in physician offices, they're using, and essentially there's a cut point, which some folks in the room have written about, around $480 or so, that if a drug less than that, you're actually being paid more. If a drug's more than that, you're actually being paying less. But we think what we're paying is covering the provision in all cases. Turns out physicians use slightly lower cost drugs, so in aggregate have a plus 0.2 or 0.3. I always forget the number. It's in an impact table. I believe it's 0.2. So a slight shift into the physician space. And then we do actually impact tables by specialty, which are also in the rule, which you can see actually have less of an effect than you might imagine. So generally, in most specialties, it's a plus or minus, less than 1% in total. And once again, we think is sufficient to cover the provision of drugs. I was sorry to answer. I said I'd answer shorter, but I was the subject of a write-in campaign from patients that literally was saying, my doctor says I can't get the medicine that I want. I'm very angry. Well, I'd be angry about that too, if that were true. But fundamentally, we want doctors to prescribe the right medicines, and we want patients to get the medicines they need. And if there's examples where, that's not true in this model, we'd want to know about them. And so that's the construct as is proposed. And like I said, if we need to, we have heard from some smaller practices, for example, that say, our negotiating power isn't what larger areas are, so you need to think about adjustments in smaller and rural areas, and et cetera. That could be legitimate. We need to see the data. We need them to give us some level of evidence and information, because that's how rulemaking works, so then we can make adjustments. But if, there are legitimate times where this would limit access, we want to know about them. Other questions or comments? Okay. Dan.
Thank you, Dan Todd, a healthcare consultant. Dr. Conway, one of the things that you comment on, I think certainly everyone knows you're credible in this and talking about stakeholder engagement. You have an impressive record with it. OCM, as an example, was a multi-year engagement with CMMI. And I think every stakeholder, whether it's patient, whether it's physician, felt really good about that process. I think one of the things that you probably see from a full room here is the anxiety associated with the full stakeholder process and beginning the program of fundamental shifting revenue from practice to practice, budget neutral for the system or not, perhaps not for that practice. And we know that these practices are under pressure as they're selling out to hospitals. Can you comment a little bit on the very aggressive timeline for this?
Yeah, so, certainly one on the timeline, like always, we look forward to comments on the timeline. I'd highlight, when because we decided to go through rulemaking, which we thought was appropriate here because it's public, you take comments, we thought it was the appropriate approach. That did limit our ability. We got sort of pre-rulemaking input, and then, as you know, then we had a period where you're in rulemaking and you have to go through that process. So now we're back in this public process portion. I actually think this model also can be multi-year input, and let me describe. So, my hypothesis is the value-based and outcome-based portion of this, the so-called phase 2. The so-called phase 2, the outcome-based portion of this, I think is multi-year and deep engagement. My hypothesis is to get it right, you have to test how to do it in one area with input from patients and manufacturers and providers and doctors and consumers and purchasers. Learn how it works, then think about how you do it in other areas. That's not, as you know, I can't commit the agency to the exact time frame for years in advance, but my hypothesis is that it'll be a very thoughtful, engaged process, and could take, year plus to really go through that process and sort of thoughtfully roll out area by area and learn along the way with deep engagement and input. Other comments or questions? Oh, okay.
Hi, Patrick. Mike Miller of Foley Hoag. I want to follow up on something John had said. In terms of the distribution across practices, across specialties, you guys did a good impact table. And one of the policies that you guys have pushed, and I think Congress has, is sort of greater support for primary care, which the impact table shows there would be a bump for general practice, internal medicine. But it also has a bump for some of the most highly compensated subspecialties like orthopedics. Was there any consideration, or would you be open to comments about adjustment based upon specialty?
We would certainly be open to comment. We're open to comment on anything. This will give me... I'm actually quite careful. On the process, on the impact table, we determine the policy internally. That's actually good for people to know. And then we get an impact table, which I would argue is better. Because you're determining policy based on merits of policy, and then you see the impact table. And then if the impact table has things that are unexpected, we'll sometimes have to go back and think about, do you need to make different choices on the policies? I think we'd be open to both comments on the overall impacts, including in ways that you named. We also would be open in comments, on the distributional impacts, and should we think about those differently, both across hospitals, physicians, among physician groups, et cetera. So I think that, and most importantly, I alluded to this, but I'll say it again because we sometimes, like a comment letter that says, I wish you would do this differently, like X, as you know, I know you know, but not nearly as helpful as I wish you would do us differently because here's X, Y, and Z evidence-based, data-driven reason. That is incredibly helpful, more influential to us and everyone else in our process. So we look forward to those type of comments and input. Any other questions or comments? All right. Oh, okay.
Let me ask, thank you, and ask a last one. Patrick, you've emphasized this morning and in the proposed rule, the budget neutrality. Mm-hmm. But the proposed rule also pretty openly considers that this change in reimbursement may change utilization of high-cost drugs. If you go through this whole experiment and total expenditures on drugs don't change, if it truly is budget neutral, will it have been worth doing?
Yeah, so thank you for the question. There's actually three ways, and there's three ways an innovation center model can meet criteria for expansion. One is improved quality and lower cost, which we think is a possibility here, but we'll see. The other is lower cost and quality neutral. The other one, which we focus on but doesn't get as much focus on externally is quality and outcomes better, but cost neutral. So any of those three outcomes actually is a good outcome, in my opinion, because if quality goes up and costs are neutral, that's good for our system. That's better quality at equivalent cost. And so I think Congress, in the way it wrote the statute, that was very helpful to give us three pathways to expansion, all focused on better health outcomes for patients. So, we think this model has promise. We also, as I said, know that it will be shaped by input by all those in this room and others across the nation. We look forward to that input, and if it's okay, I'll end where I started. This model we believe, can help improve patient care. We think access and patient outcomes are paramount, and we'll focus on that. We also look forward to your comments and your input to help shape this model over time to make sure it meets the goals of better health outcomes for patients. Thanks a lot for your time. Really appreciate it.
I'll welcome our panel to the stage now. Thank Dr. Conway again for being here and for setting us up nicely for the rest of this morning's discussion. As our panel takes the seats, I'll just let you know about the format for the rest of the morning. We have a lineup of distinguished speakers who spent a lot of time thinking about this and related issues on how ongoing changes to the payment system are reshaping our healthcare system. We've divided this discussion today into two parts that track phase one and, as Dr. Conway said, the so-called phase two of the proposed Part B experiment. So we'll begin initially by talking about changes to the ASP reimbursement formula, shifting from or comparing ASP plus 6 to ASP plus 2.5% plus a fixed reimbursement fee of $16.80. We'll also spend some time in this first session considering the experimental design that CMS has proposed. After a short break for coffee, I'm going to hand the moderation over to my colleague Chuck Shih, and we'll have the panel focus on so-called phase two at some of the value-based approaches and what might be tried and evaluated there, what the right questions are and the right approaches. We keep the same panel all the way through this morning. Let me now introduce the panel. Start on my left with Peter Bach, physician and director of the Center for Health Policy and Outcomes at Memorial Sloan Kettering Cancer Center, where he leads research efforts on a number of prescription drug-related topics, including the development of new pricing models. Stephen Grubbs, vice president of clinical affairs with ASCO, with the American Society of Clinical Oncology. And before taking his current position, Steve was a practicing community oncologist. Laurel Todd, vice president of healthcare and policy research at BIO, the biotechnology industry organization. Jack Hoadley, research professor at Georgetown University, whose research focuses on healthcare finance, including Medicare. He's also a longtime commissioner on MedPAC. And Stacy Sanders is the federal policy director at the Medicare Rights Center, which works to ensure that older adults and people with disabilities have access to affordable health care. Medicare Rights has been involved for a long time on access to drugs and on the Part B and Part D program. I should mention that we did have a sixth panelist, Kavita Patel of Brookings, who unfortunately had to drop out at the last minute today due to unavoidable circumstances. But very glad to have the panelists with us. I'm going to start just by a sort of setup question. Congress created the ASP plus 6 system in 2003, in part to curb rising Part B drug prices under the previous reimbursement system. Drug prices are rising now once again, and many, including CMS, have pointed out that under the current system, providers get more revenue from choosing higher cost drugs. So is it appropriate to look at a change to the system? Well, I'm just going to start on my left. Peter.
Yeah, sure it is. As you pointed out, we ended up with this ASP system because it was an incremental change from the AWP system, which had which was in itself an incremental change to get essentially patients with cancer at the time, who dominated the Part B space, out of hospitals and into doctors' offices. And like many things in healthcare, when it was implemented, the cost of most drugs was pretty low, reasonably inexpensive. And it was a way of getting a sort of cost-plus methodology into clinical care. But once it was unleashed on the outpatient side, it turned into a sort of its own beast. And the AWP disassociation from reimbursement rates got wider and wider, prices rose, and we had a shift towards a financing model of community oncology, or doctors' offices particularly, which was around the spread, this difference between this published price and the real price for doctors. And so, as you noted in 2003, there was an attempt to temporize or attenuate that gap by at least trying to pay some version of cost plus, which was this average sales price method plus a small margin. And we've seen there again that as prices rise, because it's a proportional profit, that essentially creates an ability for drug companies as they raise their prices to essentially get market share, because the profits that carry along with those high prices continue to rise. So even if the spreads change, the fundamental math still is there. So this pilot in the regions exposed to the new formula will have that further temporized, also still present. And there'll be a move towards what probably makes more sense, which is that doctors be paid a sort of flat overhead kind of rate for the complexity of dealing with the medicines, and much less paid around the dollar value of what's in those vials.
Steve.
Yeah, so, and Peter's made a good point there that we have had changes in the reimbursement of physicians in their offices over these last few years. And I think the issues are, it's not clear that these changes actually have changed prescribing patterns, and fortunately, prescribing patterns still remain based on evidence-based science of what's the best thing for the patient. And I know we've had a publication, two of them in the last year and a half, that have shown in an experiment by United Healthcare that indeed changing the reimbursement for drugs didn't change the prescribing issues, and indeed their program, the drug costs went up, despite the fact that the overall cost for patient care went down for other reasons. And I think there was evidence in a publication looking at when the MMA kicked in that indeed there were factors more than just drug costs that actually did the prescribing, and that the science still won out in the end. So I think beginning to fiddle with these, we'll talk about it later, has certainly unintended consequences. And I think the first question is, should we be looking at a different system? Absolutely, we should be. This ASP plus 6 is not a good system. I think most of us in oncology believe that's the case, and there should be a value-based system out there, but it needs to be actually more comprehensive than just looking at the drug costs. And we'll talk about that as we go on, what models we have working right now within the physician oncology community to try to get to better value at a lower cost, and it has to involve more than just drugs.
I would agree with that it has to give any solution that we're looking at or any model that we're considering has to give credit to drugs for their role in caring for patients. So an oncology care model, for example, looking at a more broader oriented system. I think, looking at Part B drugs just in a vacuum, one, you can see the trends over time that the switch from AWP to ASP created a relatively steady system that we've seen since 2006. And that you risk exacerbating other trends that are ongoing in the system to just look at turning a dial on +6, because you do a disservice to the rest of what's happening in the system. So the United model shows that drug utilization went up when you put a cap on total cost for a care. You have to start looking at what's happening in physician offices versus hospital outpatient, and trends in consolidation and direction there, and make sure that you're not exacerbating other trends that are probably much more impactful on overall costs than just turning a dial on +6.
Jack?
Thank you. And I would just say, you mentioned that I'm a member of MedPAC. Anything I say here today is my position, not the position of the commission. I think one of the things that I think has changed since 2003 when the ASP put in is we're seeing a lot more high-cost drugs on the market. The kinds of costs that we're seeing in the system and the kinds of costs of drugs that we're anticipating over the next few years is going to be higher and higher. And so I think it does make sense to try to take a look at the incentives created by the ASP system, the +6, towards high-cost drugs, regardless of even what the degree of evidence. And we really haven't had a lot of study on sort of how prescribing changes, but it does create an incentive, and I think that's something we want to address. And there was concerns when we moved from AWP to ASP that would be a significant disruption to the system, one that would cause all kinds of problems. It actually ended up going fairly smoothly, and I think right now we're in that phase of sort of fear of the unknown and looking at some kind of an alternative. There's a pretty good chance that if we design this right, these kinds of changes that are being proposed can also work smoothly and improve access and outcomes.
Stacey.
Yeah, I think we absolutely agree that it's worth looking at the current reimbursement system, and I think we share the concern about the incentives that are included in the current system. But more importantly, our support for CMS's proposed model is really driven by what we hear directly from Medicare beneficiaries and from patients. So my organization operates a national helpline. We field about 15,000 calls every year and serve a total of over 2 million Medicare beneficiaries. And concerns about affordability are among the top things we hear from our callers. And many of those callers are people who simply can't afford Part B medications. Typically, that's cancer medications or immunosuppressants. So I think Dr. Conway's point is very important. The current system is not serving beneficiaries well. There are real access and affordability issues in the system, and so it is time to revisit the status quo and look at opportunities to move forward in a way that improves healthcare quality and ultimately makes the prescription drugs that people need more affordable and accessible to them.
So we want to understand the effect on care delivery that this proposed change would have. But before we do that, I want to pick up on something that Peter mentioned and Jack alluded to, which is the idea that reducing or changing the margin, adding a fixed fee, would actually act as a brake on rising drug prices. So independent of the effect of this experiment on patients and care delivery, and we are going to talk about that, I'd like to know if each of you sort of accept that contention that this shift, this reduction in the +6, could slow the rise of prices. Maybe I'll just come back this direction. Stacey, I don't know if you have thoughts on that.
So I'll speak a minute to that, and I think there is the potential of having some kind of a response, and I bring a couple of pieces of evidence to that. One is some data that MedPAC staff presented at recent meetings on the impact of the sequester. Nobody would claim the sequester was a well-designed policy intervention. It certainly was not. But one of the things that we saw in the data was that manufacturers seem to have adjusted prices in response to the sequester. So when you look at the point of time where the sequester intervenes, the average price as a percentage of ASP, the average actual price that was seen on the invoices dips down starting in that quarter and stays down. And that, to me, is evidence of a broader phenomenon that you can look at international evidence for in places like Australia with their reference pricing. One of the responses that you're sort of looking for is a manufacturer response to say, okay, here's some rules, we want to stay in the marketplace, so we're going to make a price adjustment accordingly. Of course, you're also looking for a provider response. If there's an incentive, and the Inspector General has talked about some of the evidence on the macular degeneration drugs where there's two competing products at very different prices, a sense that if the playing field were leveled on that, that would create better incentives to use the less expensive price. So I think you're looking for both a provider response and a manufacturer response on this.
I want to key off of that. One of the concerns with the MedPAC data is it looks at 34 drugs, but it blends hospital outpatient department, physician fee schedule, ESRD. So you don't know when you're looking at the practice mix that's within that, whether they're small and rural or large practices. So you really don't know kind of what the buying power is within those different groups. Hospital outpatient departments have a very different acquisition profile than a practice, a small group practice might have. So I don't know that there's necessarily so much weight that we can attribute to manufacturer response as a result of that study. And to the second point in terms of the provider incentives, there is a study that looks at the differences of macular degeneration drugs in Medicare versus the VA, where the theory being Medicare has a financial incentive to prescribe one product over another, whereas the VA doesn't. And what we see is that the preference in the Medicare program is for the cheaper drug, which is directly counter to what, tinkering with +6 and what the incentives we think might be there. The evidence suggests that the incentive actually isn't carried out that way, because at the end of the day, physicians are doing what's right for their patient.
I want to come to Stephen and Peter on this, but just a quick follow-up on that. You pointed potential limitations of the MedPAC data, but from an industry point of view, does it have face validity that this change would slow the rise in price growth?
I think it's very complicated in terms of what your exposure is in Medicare, who is acquiring your products. It's a very complex system in terms of whether it's a direct sale from the manufacturer versus through wholesalers, and kind of, at what point in time all of those things are happening. It's much more complex.
Can I take that as a maybe sometimes?
Maybe sometimes.
Stephen?
What about sometimes maybe, Laurel?
Well, let me start out by saying here what the real world is, Alan, how physicians and their practices are being reimbursed here. We're not at ASP +6. We had sequestration, and we're actually at ASP and 4.3%. So that's really the real world. And I know it's nice to have us theorize at ASP +6, but we really are 4.3. And I don't see sequestration going away anytime soon. As a matter of fact, I think it's there till 2014, or 2024, which will be beyond this experiment. I think the second thing is based on this model that sequestration part 1 will be added to, the ASP drops to 0.86%, less than 0.9%, and there's a small add-on on that. So I think, when we have this discussion, we need to really look at the real-world numbers that the physician practices and the patients are going to be involved with. I can't comment on how manufacturers are going to respond to this. I can comment on how I think physicians will maybe make the hypothesis or not make the hypothesis that prescription changes will happen, at least in the oncology field. And I think, and Peter can maybe comment on this too, I think the opportunities are there on a couple things, but not many. We really don't have that many options in the oncology field, even with the expensive drugs, to shift to really super lower cost drugs. So I can't comment on the manufacturing, but I think the numbers we really need to look at is what happens with sequestration, because that's where we live today.
And so we are going to come back and spend a bit of time on that, but just sticking for now with you opened with this, Peter, but do you want to say anything else about the potential to act as a brake here on rising drug prices?
Yeah, well, no, Alan, thank you for the question and the comments of my colleagues up here. It's great, actually, to have a policy discussion that views policy as dynamic rather than static, which is the nature of your question, but you are asking us to speculate. So a couple things. One is just to clarify the United Healthcare demo, which has been brought out twice now as proof that incentives don't drive practice. The underpinnings of that demonstration was a pathways program. And so the therapies that were chosen by the doctors were preordained by the contracting process. And so you would expect, once you embed that into the demonstration, you wouldn't imagine much further prescribing. So I think I'd be cautious. What CMS is doing well here is they have isolated the impact of ASP formula changes without embedding these other things. And even when they have value-based structures, which we'll talk about, those are further factored into a study design. So let's be clear about what is and is not likely changing that. But on this other point, so we have a little plug here. We have a report that just got posted today that the Wonk blog picked up on the Part B payments and prices and what's happened over time. And the prediction would probably be that, like Jack mentioned, inflationary trends of expensive Part B drugs would be temporized. What we describe in that report is if you look at the most expensive drugs, and by the way, we talk about this huge basket of drugs, but this is all about, for example, about the top 10 drugs in cancer account for about 70% of spending, and they're the big name drugs we all talk about. If you look at those drugs and their ASPs over time, over the last 5, 6 years, they rise by about 1.7% every 6 months in price across the board. And that number is important because, as you just mentioned, the headroom, there's a lagged price for 2 quarters, the headroom's at 4.3%. And so manufacturers, by raising their prices only 1.7%, are essentially compressing doctors and hospitals' margins from underneath, but leaving still a little bit of profit. So the prediction would be, under a model in the regions that are affected by the pilot, if it goes down to 0.9%, that would take away that headroom that the manufacturers have. And so they would be left with a different set of choices. Should they continue to raise prices as they have been, which essentially puts docs underwater for the expensive drugs, or would they in fact slow the rate of rise of their drugs? Jack did mention their analysis of pre and post sequestration. We have been trying to look at that question as well. We're seeing a slightly different signal, but it has a lot to do with, as Laurel mentioned, what basket of drugs you include. We definitely don't see an uptick after sequestration, which was, because of its irrationality, a great kind of experimentation on payment.
So the prospect of docs being underwater is very important. So one man's headroom is another man's operating deficit. I want to spend time on that, but before I forget, I keep neglecting to mention that in your packet are cards, and we will collect questions from the audience, and folks will gather them up, and we'll sort of feed them into the discussion as we go. So if you have questions and want to pass them to the ends of the aisle, we'll feed them into the discussion as we go. So this question of docs being underwater. So let's just establish a baseline here. So the ASP plus 6 is a manufacturer reported price. As has already been pointed out, that's reduced currently by sequestration. It's also not physician reimbursement because there are other components of that that don't reach the doc because of prompt pay discounts and other things. So docs are operating here on average with way less than plus 6. But on average is, of course, always very deceiving because there's a spectrum of folks who are operating above average and below average. So I would like a response from each of you about, as we move towards squeezing the margins for high-cost drugs, how should we think about the potential of practices being underwater? Let me go to you, Steve.
Sure, yeah, I'll start out with that. I think, that's really a major concern, and we're trying to find out from practices and our members in ASCO, if this goes in place, how many drugs actually do go underwater. And again, the issue is acquisition costs are different between practices. Smaller practices have higher acquisition costs than larger entities, and we know that ASP is the average, so there's got to be people on both sides of that. So acquisition cost is an issue. What I've heard from a few preliminary practices to date is the number of drugs that go underwater may double at this lower level. Now, what's interesting in this model in phase 1 is
Number of drugs, number of practices?
Number of drugs go up by about 50% to go underwater. I'm not saying the practice is going underwater, the drug. So if you have, currently, there's drugs underwater right now. It may be, I've heard some practice say they may have 8 or 10 drugs. It may go to 20 drugs underwater at this new proposal. We've got to get that data. We're trying to collect that right now based on the practice's acquisition costs, what happens. And of course, we're not privy as an organization to acquisition costs. That's contractual for a practice, but we can predict what the payment would be, and so that there will be an increase in underwater drugs. Now, what's interesting is I read through this phase 1 model. I think everybody took into consideration trying to keep drugs for the practice from going underwater, and it looked like the break point was ASP at 2.5. That's why ASP plus 2.5 was put in there. So the reality is we're not going to get ASP plus 2.5. We're going to get ASP plus 0.86. So the whole premise of trying to keep drugs from going underwater in practices is not going to be met with sequestration, which is the reality here. And again, I would argue we'll see drugs go underwater more than there are right now.
And CMS actually points that out in the context of the demo, where they point out that ASP plus 0 is not viable for practices for exactly that reason. Yet, with taking into account the effect of sequestration, that's essentially what they proposed. And so you can't look at, when it comes to sequestration, you can't look at it in a vacuum and say that's going to happen on the outside, because practices, it seems there is a specific inflection point where practices go underwater for a significant portion of their drugs. That there should be a % add-on related to the cost of drugs is, I think, something that is kind of sitting in the background here, but I'll come out and address that directly, that there is of course a point of a percentage of the add-on that has to be associated with the cost of the drug, because at least in a buy and bill, there's an amount of time where the provider has to acquire the drug, has to get a copayment from the patient, and then get reimbursed for the drug at some later point. The dynamics of a flat add-on here, 1680 is a number picked out of thin air because it makes the numbers balance in as a matter of being budget neutral, but it does not actually take into account the actual cost for a practice of acquiring and maintaining the inventory necessary to provide these drugs to patients.
Jack, how do you think about this question of putting practices underwater?
You know, one of the things that this makes me think about is some research I was doing post-2003 when the ASP first got in. And one of the common things that we heard in the interviews that we did around the country with oncology practices, and then also with some non-oncology practices as well, was fears about drugs going underwater. And that was under the 106% pre-sequester. And I think one of the lessons there is the system, you know, this is intended to change incentives in the system and force some adaptation. And whether we see adaptation from the price side, from manufacturers, whether it's prescribing changes, some of which are part of what's intended here to get better access to the right drugs at the right times, you know, that is the point of trying some new things to try to address what we're really concerned about, which is an upwards price trend. I would also mention that, you know, this is, as Dr. Conway said, a proposal, and you know, at MedPAC we've been talking about these kinds of formula changes, and we've looked at a variety of different combinations of percentage add-ons and flat fees, different from the particular one that's in this proposal, and could range even from a completely flat fee-based system where there's no percentage add-on to one that our staff looked at for us in the recent meetings, which was 103.5% plus $5. So a little more of a percent, a smaller thing. That was actually not budget neutral. That was designed to create some savings below budget neutral. So I'm not, you know, convinced that any particular formula is the right one, and that should be part of the conversation, is to try to think about whether there are different formulas that would better get at the sort of changes we're looking at. And obviously, you have to look at it in context of the sequester. But again, the sequester is the reality, and as Dr. Conway said, this particular formula was designed to add, not add or subtract money, at least given no, you know, in advance of anticipating behavioral changes.
Yeah, I think, you know, Jack raises an important point, which again, this is a proposal, and I think we would be very open to, you know, changes to the proposed reimbursement model, ASP model, that would prevent physician practices from going underwater. That's certainly not something that we want to see, but my primary concern is beneficiaries who are underwater. And I think important context for this conversation is that the median income for a Medicare beneficiary is about $25,000 a year. And only 1 in 4 beneficiaries have $12,000 in savings. So co-payments that are, or co-insurance that is hundreds of dollars a month, thousands of dollars a month, are simply not affordable to people who lack adequate supplemental coverage in Medicare. So I think we do have to be concerned about physician practices going underwater, but we also have to recognize that there are many people with Medicare who are already underwater when it comes to paying for these prescription drugs.
Stacey, on that point, so the high-cost drugs, the patient copay will fall under this proposal. For low-cost drugs, it will actually rise. Avalier puts the breakpoint at $480. How does your organization think about the fact that beneficiaries will be paying higher out-of-pocket for the low-cost drugs?
Yeah, I mean, I think we recognize that is an outcome of the model, and certainly, you know, we don't necessarily like to advocate for increases in cost sharing for beneficiaries at any level. But I think the potential gains for people who have those very, very high-cost medications could be so significant that we do need to move forward with the test. And of course, and we will encourage CMS to monitor for beneficiary access for all prescription drugs, not just the high-cost medications, but also the lower-cost medications where there will be some increase in the coinsurance.
Good. Laurel, I'll come to you. I don't think I've come to Peter yet on this question of underwater, so let me do that, and then I'll go to Laurel.
Yeah, no, thank you. So, a couple things. One is, for sure, this is a rejiggering, and again, I'll plug our report from today. This is a rejiggering of the margins. And so, yes, some drugs, particularly those that are high cost, the profits will shrink, although they'll still be there. And many of the less expensive drugs used in oncology, including some important backbones like paclitaxel, the profits for doctors and hospitals will rise per administration. So the idea is, on balance, for it to work out. And I think this issue of individual practices being underwater is an intriguing one. Obviously, there's some issues with, can you really see, can you get transparent information on it? But, again, dynamic versus static. The reason we have relatively broad variation in acquisition cost is because the headroom on the percentage add-on allows it, plus the commercial headroom, which is whatever, 24, 28% for docs and 50 to 100% for hospitals. And so that allows manufacturers to do things like volume-based rebating, growth-based rebating, other things to essentially buy market share through rebates, which does spread the acquisition costs and thus affects doctors who can't grow their volume at the same rate as other docs, having to pay higher acquisition costs. So the real question, and obviously, and Laura will tell you this, many of her members have gone to limited distribution networks rather than through traditional distribution channels in order to tamp down on all the intermediaries who are inserting these kinds of programs to level out access. So if we went to a system where margins were tighter, one possible response of manufacturers would be to distribute drugs on pricing that's tighter. And that would be good, and it would actually be good for small practices to sort of be on a level playing field. And it would just generally be good for patients to not walk into practices where doctors are facing volume-based and growth-based rebating incentives to use expensive drugs. So I think both of those things are we have to keep in mind.
Laurel.
So to the extent that patients no longer can access care within an underwater community office, that means that that patient will access care in a hospital outpatient department where we know their costs are much more expensive and their out-of-pocket cost will be more for the same care. And so I think that that's something we have to keep in mind in terms of what are we doing. Sure, 85% of beneficiaries will be paying more out-of-pocket, small amount, but 85% of beneficiaries, encounters, will be paying more out-of-pocket. As a result of this proposal. And so if you're driving more patients into, if more practices are underwater, those patients will likely end up in the hospital outpatient department where their cost sharing is a lot more than kind of what you might be seeing as a result of this demo. And so what we don't know as a result of sequestration is what have the referral patterns changed in terms of where beneficiaries accessing their care. And then once they're in the hospital outpatient department where they're getting more drug and more expensive drug, which is not good for the patient, certainly, in terms of their cost sharing, as well as for the system generally. And we have to not look at this in a vacuum that a little bit of change here is going to cause a big change in places that are actually really driving costs. And we know inpatient and outpatient care is what's driving increases in premiums. And drugs come in third behind that list. And so we really have to be mindful of what's happening across these different components of the system.
I think I see Jack and maybe Steve. So,
yeah, I mean, I think Laurel's raising an important point. It's one of the key things we need to monitor in whatever is done in this demonstration, or even in the absence of a demonstration, just as changes occur with sequesters and all other kinds of things, are there shifts in how care is being delivered? Shifts across drugs, shifts across sites. And I think, one of the outcomes we don't want to see is a dramatic increase of care shifting from physician-run offices to hospital outpatient. That, to me, doesn't say this isn't a worthwhile project to do, because part of what we're expecting in any kind of thing like that is a behavioral response that could take other forms, and that's why this is being done as an experiment. Again, when I point back to the innovation of ASP in the first place, that's again one of the things we heard regularly when we were talking in the very first year, even pre-implementation. This is going to send everybody out of our infusion centers and over to the hospital. And there was definitely some shifting, but we didn't see the kind of dramatic shift at that time that people were fearing.
Can I just comment on that? And two things I want to comment. First of all, there has been a big shift in the last 10 years from the office-provided infusion services to the outpatient. And I think Milliman just had a report out just recently that shows in the last 10 years, the amount of infusions done in the hospital setting has gone from 15% to 45%. So there's been a tremendous increase in terms of the shift. And I think this all has the potential of even accelerating that even more. But the point I want to get back to, and I think Stacy made a real good point. Listen, as a practicing oncologist that I was until 7 months ago, the cost of care to our patients was a major issue for every practice and every physician. And it was our job to make sure they got the best drug under the best financial circumstances. And it has been a part of our practice from ever, trying to help every patient get the drugs they need. And I can tell you, I was on the board at ASCO for the last 3 years before I took this job with them. And I can tell you at the board level, this is a discussion all the time. The community oncologists understand it, and it's become a major issue with ASCO. How do we control the costs of healthcare and still give our patients the care they need? So I want to make sure it's very clear. As a practicing oncologist, I understand it because I had to help my patients get what they needed. And it's not easy, and it's hard, and it's a thing every practice has to do, and it's a major effort we have to do. So the answer is we have to do this right to get these costs down. But I'm afraid this phase 1 model here is actually going to push us backwards rather than forwards on it.
Because it's going to shift to higher cost hospital sites?
I think that's one issue, and we can talk about how that might affect patients in terms of disrupting their care. I'll give you, we want examples. I have had times in the 31 years in practice, mostly in the last 5, that there were times where drugs went underwater at a big enough level that I could not afford to subsidize the payer. And for short periods of time, my patients had to go to the local hospital infusion area to get their drugs. And the answer is they were willing to do it because I sat down with them and said, this is in your best financial interest to do this. Even though there was a disruption of care, they would have preferred not to have done it that way. That has happened at times. I've had to do that because I just could not afford to take a huge loss on drugs. And I can tell you in our practice, what we did is we had drugs underwater. And what I used to do is I used to look at the entire combination of drugs we gave. And if the entire combination of drugs stayed above water, we would take a loss on specific drugs. So we always try to do the best thing for the patient. And the patients understood that, and they appreciated it, even though there was some disruption of care.
Did you want to get in?
Yeah, sure. So a couple things. 3 really. ASCO to be credited for the value framework for sure, right? Real leadership on this issue of pricing, affordability, and benefits. So kudos to the organization. Everyone, I work mostly in the cancer space, and everyone has been very concerned about what reimbursements rates would do around drugs to the practice of oncology, the access to Medicare beneficiaries. But the latest data that I've seen shows that oncologists are actually the highest participating providers on a proportional basis in the Medicare program, right, of all the subspecialists. I think it's well north of 93, 94, maybe 96% of oncologists are Medicare providers. And that's 10 years after this change. So it is viable. The other thing is this site of care shift. So this is, as I understand it, we talk about the shift to the hospital outpatient department. And I think for us, the visual is that more and more patients coming to places like where I work, Sloan Kettering, a huge brick building, actually multiple brick buildings, and away from doc offices, which we visualize as a small practice that has high touch, high feel. But the primary driver of the dynamic is change in ownership, not change in location. And so what we have is many practices being either acquired or otherwise entering contractual relationships with hospitals, flipping their name, getting new stationery, and all of a sudden they're hospital outpatient departments. I'm not saying that's good or bad. It's primarily driven by the 340B program, which ironically is a reimbursement issue that has greatly distorted the market. But now we're talking about rejiggering reimbursement, and we're not supposed to do that. But this is, so when we talk about, again, the visual here is more of the docs have seen merit in selling their practices because there's a huge arbitrage opportunity. Their practices, although valuable and profitable to the doctors, are magnificently more valuable to 340B hospitals. And so they are taking their opt-out, they're selling their practices, they're moving as employees or getting professional service contracts because that spread is so large. And it's all about drug reimbursement and the profits associated with it.
I think you'd agree with that, Steve.
That 340B hospitals acquiring practices is clearly a part of this. Having said that, if you look at, I think, the most recent Milliman data on the outpatient services, 50% of the hospital outpatient services were done in 340B-based hospitals and others were not. So the answer is that's not the only part of this equation.
340B, though, is a drug acquisition program. The reimbursement rate's the same in both the OPD and in the physician office. So the difference there is the acquisition cost, not the reimbursement rate. And that's what's driving what you see a differential in growth in Part B drugs. The ASPE report points this out. You're looking at 5% annual growth in physician office, but 13% in OPD. And so when we're looking at proposals, we should be very specific about what we're trying to impact.
Yeah, well, the profit margin is dictated by the acquisition price falling, so it's still about profit margin.
I would just point out that the acquisition of practices by hospitals is much broader than just the impact of 340B. It's really happening system-wide across specialties because of some of the site of service differentials in payment, which can be separately addressed, and Congress has at least taken a step in that direction. So that's a much broader and more complicated issue.
So on the question of whether there are alternatives, and Steve, you raised this in your opening remarks. So if the reduction of financial incentives to choose high-cost drugs is to shift prescribing to lower cost alternatives, we have to see that potential there clinically. According to Avalere, 7 of the top 10 drugs are oncology drugs. I'd love each of you to give a perspective on if we accept for the moment that changing the incentive system will change prescribing, are there clinical alternatives that would let that happen? Steve, let me go to you first.
I think we can find several examples of where we have equal outcomes with a very expensive drug and an inexpensive drug, but there are not as many as I think you believe there are in oncology. Maybe there are in other areas, but there are some examples, and again, I think Peter pointed out that ASCO has worked very hard in trying to get to better value at cost for patients, and we have this framework that we've developed trying to look at the value of an outcome of a treatment in terms of the benefit to the patient with the disease and also the toxicity, and then try to put it in relationship to the cost. But there are other programs we have. There's a program of choosing wisely. And again, I think that may be an opportunity to take some of these few examples and put them into the Choosing Wisely campaign, which is basically saying that when you look at all the evidence, you shouldn't really do this. It's not a cost-effective way. And again, that's something we can easily monitor. So I think that's possible. And then on top of it, ASCO, along with CMS, with their oncology care model, have new alternative payment model systems out there that are going to try to take this whole drug thing out of the entire equation, but reform the entire way we practice. And this is, I think, a very important point here. This is a time of transformation, at least in the oncology practices in the next 5 years. We have all kinds of expectations to get to in a better system of higher quality, lower cost. And to do that, it requires resources to do it. And this is not the right thing at this time, to take resources out of practices in the oncology field at a time where they have to invest in new systems to give higher quality care at a lower cost. And I think that's really been looked at in the oncology care model. The oncology care model is actually putting more resources into practices with the expectations this transformation will occur. So I think this is just a bad time to be doing this phase 1.
And speaking about alternatives, Hatch-Waxman has been tremendously successful in the development of a generics market to the point that 90% of prescriptions are generic. We're just in the infancy of a biosimilars market where we now have 2 newly approved products, and we really need a robust biosimilars market to create those alternatives and to bring down the cost of care in long term. A patent is a short time protection, and a generic or biosimilar is forever. And I think it's very important that we ensure that manufacturers have the incentives to want to be developing these products. There's many innovators who want to get into that space, and that's what's going to create the alternatives for even greater differentials going forward.
So I'd like to explore this contention that sort of larger shifts in reimbursement underway and we should leave the drug system alone. But before we do that, I don't think we've quite finished getting folks' thoughts on the potential to shift utilization to lower cost, equally robust clinical outcomes. A very closely related question from the audience is, what can we say about the clinical impact of the current ASP +6 system? So let me, Jack, Peter.
I guess one of the things to, and Laura brought this up, is some of the real potential for changes in the reimbursement system go around the preparing ourselves for the influx of biosimilars. And I think, the rules for paying biosimilars already go part of the way, because they do say that they have their own system that's a little bit of a modification on the current ASP system. And I think that is one of the places we need to look at. We obviously just have a few on the market now, and that's one of the challenges. There also are drugs that are not in the oncology, and we've been focusing mostly on oncology here, partly because of some of the folks on the panel. But there are some, and I'm not a clinician, so I don't want to get involved with trying to say what drugs are equivalent, but there are other classes of drugs where there's some potential substitution available that we should remember as well. I do also think that, particularly on the oncology area, some of the broader kinds of things, some of which come up in phase 2 of the demo, and I know we'll get to that, could eventually have greater importance than just the price manipulation, because of the complexity of how oncology care is delivered and its bundles of drugs and different things, as opposed to, say, treating rheumatoid arthritis, where you're taking one particular drug for an injection.
And someone from the audience did ask us to focus beyond oncology, and it's a good point, and I should mention that we had hoped to have the American Academy of Family Physicians here, and they wanted to be here and just couldn't make it work. But Stacy, your thoughts beyond oncology?
Yeah, well, I think on the issue of alternative medications, we're not clinicians, so I think we can't really speculate on the specific circumstances. But we can say that beneficiaries are not well positioned to know what all the alternatives are. And generally speaking, and the research supports that when a beneficiary goes into their doctor's office, they really do follow the lead of their physician. And they tend to be hesitant to sort of question the recommendations of their doctors. This can even come up with something as simple as asking for a generic alternative to a brand name prescription drug. So I think that this model's emphasis on the prescriber incentives and some of the things in phase 2 around clinical decision support tools and really promoting best practices, it's putting the emphasis on the right entity in the relationship between the physician and the beneficiary. So where there are all those alternatives, it really, I think from our perspective, should be the role of the prescriber to make sure that the beneficiary knows what their options are and knows if there are, equally effective, lower cost alternatives for their condition.
Peter, two things that I didn't come to you on that are sort of on the table. One is sort of effect on utilization, effect of the current system. Also, I don't know if you want to talk about beyond oncology or not, but
I'm a little hesitant to talk beyond oncology,
you don't have to.
although I'm not an oncologist, I'm a pulmonologist, but we don't have a lot of drugs in this space, actually. But so in the report we released today, we actually walked through some examples, and we didn't, again, I'm not an oncologist, I'm surrounded by them, but we looked in the NCCN, which is sort of viewed as a representative authority in cancer treatment, in the Anthem clinical pathways that I think doctors have generally accepted in oncology. And we looked for some examples of substitutes just to illustrate what this demo would do. And so, for example, I think the first example in the report is 2 treatments for metastatic non-small cell lung cancer, one which includes the drug pemetrexed or Alimta, the other that uses a traditional generic drug, paclitaxel or Taxol. And for a 12-week course, which is a reasonable duration, standard-sized adult, under the current model, under sequestration, there's a $1,000 difference in profits to the doctor under the current model for using the more expensive agent, Alimta, rather than the cheap generic. Under the new model, the profit difference is about $500. That's what we're talking about in terms of temporizing or attenuating the impact of these profit incentives. We give other examples for the drug Abraxane in breast cancer, and there's one other that's not coming to me right now from colon cancer. No one thinks that every opportunity, every treatment scenario in oncology or in any other disease constitutes these sorts of potential trade-offs. But these are 3 major diseases, and they were sort of chosen because the pathways pointed us to them. In fact, the Anthem clinical pathways, I think, don't include the drug Abraxane at all for breast cancer. So, and that is a much more expensive drug than what it actually is, which is, again, Taxol. So the opportunities exist. The direction of the incentives point to higher priced drugs. So I think that gets to one of the questions. I think we can't predict, that's why you do experimentation, the magnitude of the impact, but the directionality is pretty easy to anticipate.
Steve, you look like you want to respond to that.
Well, yeah,
Just
you know,
while
and-
I've got you, can I also
Sure.
ask you to respond to something that Dr. Conway mentioned this morning, which is the impact tables, which suggest a relatively small impact. I think he said 1%.
Right.
Go ahead, please.
So let me, and Peter's right, there are a few opportunities in oncology to make that shift, and I think the Abraxane Taxol is one of the true examples of drugs with equal efficacy that was just shown in a clinical trial actually run by some of your colleagues that I participated in and actually helped the design of with CLGB. So, but I think the answer on that is rather than changing the entire system here, we ought to take those examples and say, let's approach them in a different way, and I use that Choosing Wisely campaign would be one way to do that. The issue on the lung cancer one, you are correct. If you look at the use of pemetrexate across all non-small cell lung cancers, there is no net benefit from doing that. But if you look at what it actually is approved for by the FDA, which is for, and I'm getting technical here, non-squamous cell, non-small cell lung cancer, there is a net health benefit, and you can see that in the article we published with the framework. So, you know, that's going to have to be a decision people are going to have to make. For an added cost, we have evidence that there is a net benefit in terms of toxicity and outcomes. So, I mean, these are not as easy as you think. And was your other example colon cancer?
Yeah, but I don't actually remember the details.
Avastin Erbitux?
Yes, it was.
Okay, so Avastin is less expensive than Erbitux. And if you look at the NCCN guidelines, which we all do, there is a subset of patients with certain genomic abnormalities that actually the Erbitux is designed for. And the answer is you could go with either drug first, even though NCCN suggests the Erbitux drug is the right way to go. But you know what happens in the long run? When you have advanced disease, something will work for a while, and then it stops working. And guess what you do? You go from Avastin to Erbitux. So the net effect of that is not an opportunity really to save money, because in the long run, my patient is going to get both of those drugs by the time they're done, because that's what they're going to benefit best from. So I think the biggest issue here is I don't think we've identified that many shifts in the oncology field where we can actually take this expensive drug and come up with a much cheaper drug.
So maybe that leads us back to something you raised earlier. I think I'll go to Jack first on this. This idea that there are bigger changes afoot in how we assess the outcomes of healthcare and reimburse for them, and that we ought not to play with the drug reimbursement while these other models are sort of, you know, in transition. How do you think about that, Jack?
I mean, I think the pricing formula is such an important part of it. I'd like to see something done. I mean, I could certainly, in the process of thinking through the options, I could certainly see the potential for targeting parts of this kind of demonstration in certain drug classes. And in some ways, phase 2 anticipates a more complex, involved kind of process. You talk about some of these drugs where it depends on the patient's indication. Well, one of the phase 2 ideas is an indication-specific pricing approach. So, you know, it may be a question of, as we evolve in this, and you know, this is, as Dr. Conway said, a notice and comment process, and they will make changes. I mean, we don't know how big a change, or and obviously we don't even know when or even if ultimately this is all going to happen. But the notion of thinking about the opportunities, and again, somebody with clinical knowledge can go to the specifics of this more than I can, there may be potential. But I think getting the pricing formula into this, if in your Avastin Erbitux kind of thing, you know, maybe you go even further in the pricing thing. So like they've done with biosimilars, where they say it's 6% of the original manufacturer's product in either case, so that the add-on is neutral to the choice of the two drugs. Maybe you go there on some of these classes and try something that says, let's neutralize the add-on between the choice. So if you eventually use both drugs, let's at least, you know, encourage the trial of the first one first. Now again, I don't want to get involved in the clinical specifics because I could be way off base. But the point is, use this ultimately in conjunction, which is exactly where the demo envisions, with some of the more specific kinds of innovations that are anticipated in phase 2.
So I saw Laurel trying to get in, and Stacey, I'd also like to go to you on this question of should we leave drugs aside as this sort of larger change in healthcare delivery plays out. But Laurel.
I want to make sure that we don't lose sight of the fact that it's a privilege that we have the opportunity to choose between different alternatives for a given indication or disease state, and that That's a function of a very complex ecosystem that requires
that doesn't go away here.
So since Hillary tweeted at the beginning of January, the biotech index has lost billions of dollars that has not been recovered. She sent out a tweet about us and Skrelly or something
Here
like that.
today, by the way.
But you can track that. It's something that we track very closely at Bio, is what are both the public interest in investing in our industry as well as the private capital flows, whether they want to invest in our industry at all or if they want to focus on a 50% off pair of blue jeans or something like that. It's very important that that investment dollar comes into the industry in the first place, and then two, focuses on those disease states that have the greatest need. And oncology is one of those. Part of the reason that we have such a boom on therapeutic alternatives in oncology is because of the returns. It takes a long time and a lot of risk, and you need that return at the end. And reimbursement and pricing are very much related to pulling all of that innovation through the cycle. And so, can I say exactly if you cut it this much, innovation will go in a different direction? No, but I can say that our members look at kind of their portfolios and allocate resources to research programs based on where the opportunities are.
So
and I think
this does sound like validation of the idea that this proposal would affect pricing.
It could have an impact on what is the ultimate reward for taking on the risk of developing all of these therapies in the first place. Look at antibiotics. We have a real conversation right now about the need for more antibiotics. Why is that? I would posit it's because those are largely used in an IPPS system that was focused on containing cost. And so innovation went in a different direction. And that's very important. Should not be lost.
Antibiotics reimbursement would go up under this model. Stacy, your thoughts on this?
Yeah, I mean, I think it is an important point that, the entire healthcare system and the Medicare system is changing. And there's this real commitment from Congress, from the administration, to move towards a value-based system. And every single sector of the healthcare system, health plans, physicians, hospitals, beneficiaries, and patients have been expected to contribute in that transformation. So I think we're very much of the opinion that Part B medications and prescription drugs in general should also be a part of that shift. And careful testing and demonstrations are really the hallmark of that transformation. So it's appropriate and I think necessary to really look at this space as an opportunity to be a part of that broader shift.
So I'd like to just touch on experimental design here before we break. One of the things that I know Kavita Patel would have said if she were here, and others have published on this, is the idea that randomizing by primary care service area, essentially zip code, is flawed. And I'm not quoting her, but other people have said because care delivery systems span primary care service areas, there will be the ability to sort of triage where you send your patients within your system, regardless of, depending where you're assigned. So I'd like to know if any of you are thinking about that, whether you have other thoughts specifically on the sort of proposed experimental design randomization model we have.
So on the PCSAs, something I think that's important is the PCSAs are based on primary care referral models, and this is fundamentally looking at specialty referral models. I don't know if somebody knows whether the specialty referral models mirror what's in a PCSA primary care model. Another thing that I would point out is New York City, for example, has 11 PCSAs, where Philadelphia has something like 24. How that works, I'm not sure, but I know that I'm from Philadelphia, and that it's pretty easy to move around between those PCSAs. So in cities where you have more PCSAs versus less, are you going to see it's not as challenging to drive from one to another where you're going to be randomized into a pay cut or not. And I think that that's something that, or that even has a hospital outpatient department, or the specific providers. The providers are not randomized to mirror the PCSAs. And so I think there's more questions than answers here in terms of how are these PCSAs going to work, and what controls does CMS have in place to model that when they're randomizing patients and providers into these different arms, are they taking those different patterns into account?
Other thoughts on that, Steve?
Yeah, so Alan, I think this is a very important point. And as a clinician, a practicing clinician, and a person that's involved in trials over my whole life, this to me is the most disturbing part of this phase one. And basically what we're asking for is an experiment to occur with practices and their patients. So this is a clinical trial experiment for individual patients in the Medicare system. And it has none of the protections in it to date, even though we've heard we're going to be looking at them, to protect the individual patient from potential downside risk in this. So when we design a clinical trial in oncology, and I've done that with many of the colleagues at Memorial Sloan Kettering, the key issue when you design a trial is patient protection. I give lectures on human rights. I give them outside the United States, inside the United States. The number one thing in a trial is how do you protect the patient first? And there's nothing in this part one that does that. Even though we've talked about we're going to measure things, there's nothing I've seen, maybe there will be, that says if there's an unturned consequence here where physicians actually end up giving the wrong drugs because of price incentives, how is that patient protected? There's no data safety monitoring committee. There's no way that I can hear right now, real time, that we're going to be able to see is that actually happening. And if I was a Medicare recipient, I would be very unhappy that I'm going to be involuntarily placed in a clinical trial without those protections in place. And I can tell you as a clinician, that bothers me more than the dollars in this. And I think this phase one design is absolutely not correct. It's not going to measure things properly because there may be changes in how physicians have prescribed that have nothing to do with the drug reimbursement costs. And I think the whole design is flawed right from the beginning. I would say it should be thrown out because of that.
Jack.
You know, I think to me that feels like an overdrawn comparison. You know, this is not a clinical trial in the sense that doctors are still free to prescribe whatever medicines they see appropriate. I think that, you know, what we're really suggesting here in this demonstration is rather than go in and make a policy change, as we did say when we put ASP in instead of AWP, where it was a change in law or something else that you do in the PPS or the OPPS payment system through regulation. This says, let's try it. We can argue about whether the geographic level is drawn correctly, but let's try this in a way where they can monitor. It's not, admittedly, it's not the same level of monitoring as you would do in a clinical trial because it's not the same kind of intervention where you're literally saying in a clinical trial, we're going to give drug A versus drug B. And it does give the agency the ability to monitor via claims, to change the way it's done over time in a way that's very much more flexible than what you would get if you made an absolute regulatory change or a legal change.
But this is for 75% of the Medicare population. They would be in this program change, which is essentially allowing CMS to override statute for 75% of the patients. That looks a lot more like a program change than a demonstration to me.
But it's a program change that's being done in a way that creates some flexibility and some specific monitoring whether the practices that are in the one arm of the study are responding differently than the other arm. Again, we could discuss whether a smaller scale version of this is more sensible. Should we pick 3 states and one side and 3 states and another side, or there's plenty of room to discuss scope and the specific geographical structure. But I think the idea that this is being tested, I mean, I'd be willing to go out and suggest, and there are certainly people who would say, let's change this formula by law right now. This gives more ability to sort of see if the change has adverse consequences. If there's evidence that it does, they've got the ability to go in and make adjustments rather than going back to Congress, and we know how hard that would be.
But how are you going to protect the patients that may have an adverse consequence? I mean, that's the whole risk here, is there could be an adverse consequence, and how are we going to protect those individuals while we're trying this?
Stacey, you were trying to get in. I know you think a lot about this.
Yeah, I mean, I think in phase one, I think the most important beneficiary protection is the monitoring. And I think we will really stress to CMS the importance of making sure that that monitoring is as close to real time as possible, which Dr. Conway seemed to suggest that they have a lot of tools at their disposal that will allow them to do that. And I think they need to monitor for the shifts in practices and the potential for higher beneficiary costs if people go to outpatient clinics as opposed to individual practices. One thing we will strongly encourage CMS to monitor for is a practice called brown bagging, where a physician requires the beneficiary to pick up their medication at the pharmacy, which then shifts their coverage to Part D instead of Part B. This isn't necessarily a positive or a negative. It ultimately depends on the beneficiary's coverage as to whether or not they pay more or less under Part B or Part D. But that's those types of prescribing practices are things that CMS needs to carefully monitor for. In phase 2 of the demonstration, CMS includes a pre-appeals exceptions process for payment. I think if CMS observes that they are seeing shifts in prescribing that are affecting beneficiaries in less than ideal ways, they might think about extending that process to phase 1. So I think this is, it's a flexible model, and through careful monitoring, I think CMS will be able to shift in such a way that they can protect against any negative consequences for beneficiaries.
Do each of you think that CMS has or can have in time the tools it needs to monitor the impact of this on patients? Yes.
Yeah, well, actually, can I respond to the earlier? So the issue, it's intriguing. I mean, so if we can call this a pseudo-randomized approach or something like that, it is, as Steve knows, immune to external impacts of things like new indications, black box warnings, new drugs, because they are independent of the randomization. So you're right, it could cause practice shifts, but this is kind of as close as you can get to an ideal design to examine the independent effect of a payment change, change in coverage, sort of budget neutral, and those things. But I'm trying to reconcile. We started the panel hearing that doctors didn't do things differently based on the reimbursement, and we're now hearing that beneficiary access and treatments are going to be seriously perturbed by a 2% change in reimbursement rates, and patients actually may get moved to other geographic regions for their care based on this small change in financial incentives. So I'm just sort of trying to sift through which one is it? Is it that doctors are being highly tactical and looking, at a few basis points on reimbursement, moving patients and choosing drugs? Fine. I think that is, if you will, the pretext of the entire approach. Or is it that they're simply operating in the best interest of the patients within their financial constraints, and so those things shouldn't occur? And the one thing on the human subjects, it is a sort of an interesting philosophical question, but let's be clear. Patients are constantly being exposed to changes in reimbursement, changes in rebates they can't see. Patients don't sign an informed consent to say, do you know your doctor faces a volume-based rebate that if they use more cetuximab this quarter than they did last quarter, they'll get 2% off? Patients don't know that. Those are heavily distorting incentives that are entirely invisible. At least this is an open-ish process to evaluate this change in payment at scale.
And the ultimate patient protection is, again, that the oncologist is not being told what to prescribe. I mean, yes, there are financial consequences to those oncologists or other kinds of doctors, but you, as I know you've said about in the other parts of this discussion, you're still going to make right by your patients.
And this is the way to design an experiment: perturb as few things as possible, in as transparent a way as possible, and it is just about payment in phase 1.
Let me go, Steve, and I'm going to just go to last thoughts from everyone. We'll take a break. We'll come back and talk about phase 2.
I think the answer on that is oncologists should be prescribing the right drug at the right time for the right patient. And it needs to be modified based on that person's individual needs and their wishes. Having said that, the concern always is that may not happen 100% of the time, and I would be worried some people would not be protected well with this. And I just think, after we've had this whole discussion on this seems like a big sledgehammer to take to a very complex system of delivery of cancer care that probably could be done a little better with some pinpointed targets in it. And I think there's a better way to do this, and we'll get to phase 2 on this. And I just think this part 1 is just way too much of a broad-based attack on how we're trying to take care of patients, and probably should be scrubbed and try to work this out in phase 2 with better systems and better monitoring. Because I understand. I heard today for the first time we're going to monitor this. I haven't seen what the monitoring is yet, and I hope it's there, but I can't tell you it is there.
Laurel.
I think Steve pointed out earlier that you, at least as he described the economics for his practice, that they look across the portfolio, and if they can absorb the loss on one by making it up elsewhere in their portfolio, then they're going to treat that patient. And I think what we're seeing here is that we're getting ever closer to that inflection point where you can't do that anymore within the system, and that's what I'm focused on in terms of, let's not just look at this in a vacuum. Let's look at what happens to care in holistically, and what that means for patients potentially having to shift and moving into a higher set of service that doesn't serve patients or the system well at all.
Yeah, can I make one other small comment there? And again, not all practices work this way, but I can tell you, in my 8-person practice, I was the managing partner and we had to make decisions on things. My 7 other associates never knew what the margins were on drugs. And we followed pathways. And I can tell you, in my practice, that was never an issue. What was the margin on a drug when a drug was chosen? Now, I can't tell you everybody does it that way, but I can tell you my 7 partners were blind to that.
Thank you. Jack?
Yeah, and I think it is that point that is what is some of the protection. But I think, there are economic incentives today. This is a proposal to just modify those economic incentives. It's being designed to do it budget neutrally in the sense that the total amount of pricing, yes, there may be a behavioral response intended to ultimately save money, but it is not taking money out of the system at the level of the price, even though, generally oncologists are trying to prescribe the right drug at the right time. There's certainly a role for the economic incentives. That's if there wasn't today, then we wouldn't worry about it under a change. I mean, that's the kind of thing I look at. We've set it up in a way that creates an incentive to use expensive drugs. Trying to reduce that incentive is what this is about. If they don't have an effect under the current system, then this won't change the effect clinically. I mean, I think that's the way. And I think the other side of this is if this sort of intervention, this demonstration can be improved by looking at phase 1 and 2 together rather than first phase 1 and then phase 2, that's something to talk about. If this can be targeted geographically or by drug class or by various kinds of circumstances, that's something we should talk about, and how to do it in a way that will take the biggest risks out of the system. I mean, I think we all think that was a reasonable approach, and I think CMS would too.
Stacey?
Yeah, so final thoughts here. I guess a point I would just come back to is that, this is a proposal, and it is a test. And I think there are opportunities with stakeholder engagement to tinker with the model as it's been proposed. And we will suggest ways that we think CMS can improve the model in terms of beneficiary education, notice, access to the pre-appeals process. There's a lot to think about. But the reason why it's important that this test go forward is, again, coming back to the status quo. And the reality that there are Medicare beneficiaries, a significant proportion in our belief, who simply cannot afford the medications that they need. We have all, I think, just in general, as a healthcare sector, committed to creating a value-based system. And this test is one way to move forward in that broader movement.
Thank you. So let's. One of the questions from the audience was about alternatives to buy and bill, which is probably not a bad segue to part 2 of this conversation. So we're going to take a 10-minute break. There's coffee, et cetera, outside. We will reconvene at 11 sharp, and I will save summary comments until the end today. Thank you.
That Abraxane article thing is really.
Changes are, absolutely. We haven't learned one thing. That's one we should learn.
Oh, yeah, sure. Oh, I heard that. It's okay. Yeah, no, thank you. As long as, let me see what you got here. Oh, no, this is perfect. Good deal. Yeah.
Oh, hi. I read your stuff a lot.
Does the job. Oh, no worries. Oh, did they check?
You always, hey there, how you doing? You always does a good job at organizing sessions. They put a lot of effort into it. They talk to all of us and they know the topic very well from their own work. So yeah, it pays off.
Hello, how are you? Good to see you. Thank you. How are you? Good, good. So, yeah, I know. Well, I've been talking with ARP, and I think we might start doing some visits. And there's a sign-on letter in the works from some of the. So, so definitely.
Hey there.
Okay, great.
Yeah, I think so. I was just saying to somebody, you guys prepare so well for setting up these forums. You know, it's not just throw a bunch of people in front of the room and then.
This one was a rush.
Yeah, but nonetheless, you well, that pays off.
Yeah. Oh, great.
Yeah.
That's great to hear.
Yeah. You know, I worked at the National Health Policy Forum years ago for a while, and I know what it's like to try to organize in a session and get a good conversation.
Right.
I know.
It takes work.
Well, it's
Oh, hey, how are you? Good to see you.
and then somebody says something really. We need to pivot entirely to focus.
Yep.
We finally got our meeting with CMS on marketplace to Medicare transitions. I don't know if Jane told you. No, it's on it's the notice and screening. We had worked with Jane on a big sign-on letter, and we finally got a meeting with Andy Slavitt about it. So I think Prue and Jane are going to go to that. But yeah, so that was good news. End of April. Yeah.
Hi, how you doing? Thank you.
Yeah. Yeah. Well, gotcha. I would look at comparative effectiveness proposals and transparency proposals around spending and spending on research and development. And yeah. Yeah, but I feel like that's the direction the conversation's kind of moving in. Like some things like that we would be supportive of, like Medicare price negotiations and all of that, kind of not really in the realm of practical. So I think a lot of the yeah, right, yeah, right. Yeah, I think those are exactly the right kinds of things. But yeah, I think just a move towards more transparency about all of the development costs and marketing expenses and also like how is it that they talked Laurel talked a little bit about sure sure wow
Right.
yeah. Yeah, well, ProPublica had an interest. I don't know if you
Somebody
saw it.
just
They did
emailed me who's
they did
watching
did
this
this big
online and
piece
said,
on
a
relationships
sledgehammer?
between pharmaceutical
It's hardly a
companies and
sledgehammer of a
patients and how
policy
it
change.
impacts prescribing. It was interesting. You should take a look. Yeah. Yeah. Yeah.
Yeah. Yeah.
Yeah. So yeah, I think that would be the area to look in. Comparative effectiveness, transparency. Yeah.
Now, what's I heard that was that's not you steered away from that.
I mean, I still think there's a whole lot of more research that needs to be done on what's possible and doable sort of in the U.S. I know AARP has done a fair amount of work on that, so you might want to reach out to them about it. But yeah, I think it's sort of, it's still an area we're coming up to speed on, but I feel like it's sort of a new way of thinking about, drug pricing. Yeah, so I would say AARP. Yeah, good to see you. Thank you.
I mean, it's one thing when you just get misquoted in the public.
Oh, nice.
Yeah.
Oh, great. Good to meet you. Yeah, and you know what? Good. Yeah, I know Ratana pretty well from back when she was at Inside Health, but I don't talk to her that much. I think you guys went to the ACA, right? Okay. Okay. Yeah. Great. Yeah, I forgot cards, but I will email you when I get back to the office, and I'll make sure we get on. Yeah, I know. I think it's going well. Oh, hey.
How's it going?
Good to see you. Thank you. Yeah. 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 So,
you try to think,
yeah,
okay,
it's
how do you
well, we did that letter and we're working on our comments. So, oh, and I did set some up with Christina to talk about pre-appeals.
Folks, we'll ask you to take your seats and we'll resume for part 2 of the discussion.
Yeah.
This is fun.
It's good.
I'm enjoying it.
Good. I'm
It's a
glad.
good group.
I am too.
Yeah.
Yeah. That's the challenge.
It worked fine last time, right?
So did you fly down this morning?
Yeah. It's
I know Cliff.
less time on the plane than the drive from the airport.
Oh, I know Cliff. Cliff does that
Yeah.
quick thing down.
Flying over train? Good morning, everyone. My name is Chuck Shee, and I'm a senior officer in health programs here at the Pew Charitable Trust. In the second half of our discussion today, we're going to transition our attention to phase 2 of the Medicare Part B drug payment model. And we're going to take a look specifically at the value-based pricing strategies that Medicare has proposed to test in its experiments. CMS has said that the use of these new payment approaches that pay a price for drugs based on their value isn't going to be applied to all drugs. And that's why they're coming back to the public and asking for input on when it makes sense to apply these approaches. So before we dive in and take a look at how exactly value-based pricing strategies would work, what I want to do is to take a step back and to frame the discussion, in particular around this focus on ongoing payment reform that's happening, that's changing the way we pay and deliver healthcare in the United States. So Medicare is focused on identifying and testing new ways of paying for healthcare that aligns provider payment with the quality and efficiency of care that providers provide. These new policies, which include accountable care organizations, shared savings programs, bundled payment initiatives, they move us away from the current approach of fee-for-service and to a system in which we pay based on high-quality care. If CMS is already exploring these much larger scale delivery system changes that redefine the way that healthcare is provided, it's worth asking about the need and appropriate scope of policies that deal much more narrowly with drugs specifically. So that's why we're looking to our panel today. So my first question, I'll open this up to everybody. To what extent do the payment models already being studied by CMS take into account the effectiveness of value of drugs? So let me start with Peter there.
Yeah, so of the ones you listed, so there's a couple things, right? One, and somebody correct me on my facts if I've got it wrong, but many of the things CMS is working on actually don't even consider the cost of drugs. So the accountable care organizations, for example, on the Medicare side, Part D drug spending is excluded from the calculations of costs or savings or things like that. And there's reasons for that, including that prescribing doctors can't actually see the prices of drugs because they're all proprietary within the Part D distribution system. But I think, to say the least, that shortchanges drugs within the value transformation. I think some of the bundling activities on the B side, because there is more transparency, there's potential, or the oncology care model is an example. But much of what CMS is talking about in phase 2 is about either changes to how drugs are distributed, like competitive acquisition, or actual changes to prices, right, around indication-specific pricing, and trying to tie those together with beneficiary sort of benefits or advantages, such as reducing coinsurance for drugs that are priced closer to their value.
So go to Steve.
Yeah, so Peter's right. There are new ways of reimbursement that practices and physicians are going to have in the very near future, and I think actually the macro legislation of last year is pushing physicians and practices all in that direction, particularly with advanced payment models. And advanced payment models will have drugs bundled into them, and they will be looked at different ways. So I think we're already moving in that direction. And even if you don't go into the advanced payment models, the MIPS program, which measures the physicians starting 2017 that affects their payments in 2019, will actually also be looking at how actually you spend money on drugs, both Part B in that program, and the OCM model has Part B and D in it. So, I suspect where we're going to end up here, not that many years down the road, that maybe we're not even going to be talking about Part B and how we're paying for it, because this stuff's all going to end up in a big bundle someday, and that's where you're going to have to do the right pricing and looking at it. So I think there's a lot of things underway right now. I think this phase 2 part of this model has potentially some opportunities right now, and I think there has to be a lot of discussion among all of us at all different levels, including ASCO. More than happy to discuss, are there some opportunities there to make differences right now?
Yeah, I think you definitely have to look at drugs in context, and I appreciate Peter's pointing out that you shortchange the value that drugs provide to just narrowly focus on how they're reimbursed without being able to take into account in a larger bundle what their impact is, say, on outcomes and reduced hospitalizations or whatever it might be. So that's a critical point. One thing I want to do is step back a little bit. The terminology here is going to be important. An alternative payment model is something where you're looking at, as we approach it, is kind of the relationship between, say, Medicare and the providers and how they're reimbursed. If you're going to look at the relationship between Medicare and patients, that would be more of a value-based insurance design framework. And then a direct contract between the manufacturers and CMS, that would be more of a value-based payment model. And so it's clear to make sure that which of those three buckets you're talking about as we look at these models. Phase 2 conflates a number of those models, and so you have to be clear as to whose incentives are where when you're looking at those different alternatives.
You know, it does seem like there's more potential for agreement in talking about some of these approaches, because I think people, no matter where they're coming from, you know, would like to see a more value-based approach, get away from, you know, a lot of the narrow sort of formula-based pricing kinds of situations. And so, you know, that's the promise here. I think, you know, in larger frameworks like something like ACOs, accountable care organizations, I mean, sure, the Part B drugs would be part of that bundle, but it's one relatively small piece quantitatively. And I think what this has the potential to do, and again, we can talk about the specifics of different pieces of it as we go on, but what this has the potential to do, in a sense, is almost provide tools to the ACOs to specifically take on this part of the payment system in a way that could help them save in the larger bundle that the ACA is mostly about. ACO, sorry.
Yeah, I mean, I think one of the things in phase 2 that we're most enthusiastic about is the opportunity to lower or eliminate the beneficiary coinsurance for high-value medications. And there are examples of other models where CMMI is already testing this in Medicare Advantage, in the Medicare Advantage value-based insurance design demonstration. Prescription drugs are a part of that demonstration. And so I think, you know, as I've said, and as I've, you know, many times, the cost of these medications for patients is very concerning to us. So that opportunity to lower or eliminate cost sharing is an important one and one to move forward on. I think what's exciting to us about this test is that it doesn't just single out the beneficiary incentive, if you want to call it that. It doesn't just look at beneficiary cost sharing. It has the potential to combine changes in cost sharing with appropriate provider education, with changes in provider reimbursement and payment. And the combination of those things, I think it's appropriate to look at all of the incentives across the system and not just single out one specific entity. So I think that's something that's promising about the model from our perspective.
So I want to follow up on something that Jack hit on, and this is a question for the rest of our panelists here. So everybody's essentially acknowledged that the really innovative reform stuff that Medicare is thinking about doing, what it's doing through ACOs, bundled payment, does factor in drug price and drug value. So the question then is, what is the role of this separate Part B payment model then? If they're already thinking about drug prices, drug value, and what the healthcare system will look like 10, 15 years down the road.
Yeah, no, so wait, so I think what I said was that on the ACO model, they actually are not including Part D drugs in terms of their price or in terms of the calculation or the gain share calculation. So it's actually not explicitly part of the ACO model. But again, there are sort of two ways to think about the drug pricing issue or problem or challenge. One is, how do we reconfigure the system around a set of drug prices that we take as a given? And the other is, say, wait a second, drug prices aren't a given. They are a product of the marketplace. They're a product of the reimbursement system. Much of that earlier panel was about the potential for drug prices actually to be moderated by changes in this, you know, add-on profit plus the flat fee that we see for drugs. So much of what's being proposed in phase 2 is actually a more careful look at, you know, what would the price be that would lead to beneficiaries paying less out of pocket? What should the price be for the same drug used in two different uses, where the two different indications, where the efficacy is vastly different, because currently the drug is the drug, independent of those things. So I think there's, you know, reasonable room out there to start thinking about experimentation or alternative, sort of more thoughtful, rational approaches to paying for drugs based on their value and pricing them appropriately.
So Steve, can I get you guys to respond? So in your response, specifically on the phase 2, not the phase 1.
No, I think all of us in oncology agree that moving to a value-based system is where we should be. And I think, of course, the phase 2 of this thing, I think the details are going to be how are we actually going to define the value and how are we going to attach that to the cost of the drugs. And again, I think that's certainly open discussion that I think certainly the oncology community would be more than happy to be participating in, and I think we look forward to moving that way. And I think, as Peter pointed out earlier, you know, ASCO's taken the first stab at that with our value framework of trying to, and believe me, it's the very rudimentary phase right now, and that's why it was put out to have the discussion, how do we improve it? But we're looking at the benefit in terms of the outcome of cancer, we're looking at the toxicities, and then we're going to compare that with cost in this thing, and that's how I think you begin to develop a value framework. It needs to be much more sophisticated than it is right now, and we're in the process of doing that, having learned to talk to all the stakeholders on the first pass around. But that has the potential to really to move this forward, and I think that's where we'll finally get into value-based pricing. So I think, you know, certainly we're moving in that direction and think it's the proper place to be.
I think that there is a role for CMMI generally looks at what does an evolved healthcare system look like and what are we moving towards and how can we model that now to try and see what we need to tweak along the way. And I think phase 2, some elements of phase 2 are much more in alignment with those overall goals. You know, phase 1 stands in stark contrast to that. But as it relates to phase 2, there are potential arrangements there on the value-based purchasing side that Bio and others had been working with CMS prior to the release of the rule, but there are very real legal and operational challenges that could get in the way of broader proliferation of these arrangements that particularly on the legal side, that can't necessarily be addressed because CMMI doesn't have the authority to waive what might need to be waived to allow those arrangements to go forward.
So let me transition the dialogue now to specifically the policies that CMS is proposing to look at. So Laura, you just mentioned the value-based risk-sharing agreements. Mm-hmm. What is your thinking on the other ideas that CMS has put forward?
So, you know, outcomes-based, risk-based arrangements are certainly something that some of our members are actively exploring in both the commercial and in the Medicare markets. Indication-based pricing is another one that is contemplated in the proposal that is of interest. Try before you buy is another one that's in there. I think these all stand the potential to move forward. There's some real limits there, but they have opportunity. In contrast, say, you know, a thinly veiled, least costly alternative in reference-based pricing, I wouldn't say that that's a value-oriented proposal, and Bio continues to stand strongly opposed to that type of proposal. But there are other proposals that could have legs. That said, say for best price, for example, CMMI does not have authority to waive 1927, which is where best price is housed. And so that means that you're not going to get the same level of creative thought, I guess, in the structure of those arrangements that you might get if we were to be able to get to a place with CMS that we could get certainty around the assumptions that go into, say, determining your best price beforehand.
So let me just follow up on one thing regarding best price. So it's always been a question that I've asked how much of a barrier it is, because we know that these arrangements are being created in the private sector. So to what extent, what makes Part B so different, I guess, in it being a barrier?
I think that the uptake on those types of proposals is very limited. They are in very small scope, and there's very few of them right now. I have heard of instances where manufacturers have tried to pursue these types of arrangements, asked CMS for guidance, got it too late, and then had to unwind the proposal because of the interaction with best price. And so it is a real barrier to broader proliferation of these arrangements.
Right. So Jack, I know you've done a lot of thinking about reference pricing What are your thoughts on its potential applicability in Part B?
So before I go specifically to that point, I just want to make one comment back on sort of what we were talking about a minute ago, which is, you know, the difference, say, in an ACO kind of world where any of the things, or certainly most of the strategies being envisioned here, are not something within the power of an ACO to adjust. So whether it's indication-based pricing or reference pricing or coinsurance changes. And so that, I mean, I think that's where the innovation comes here. I think with all of them, and reference pricing is a good example, the applicability of these is going to vary by situation, particularly by different categories of drugs. So to really do reference pricing, to me, one of the real opportunities for reference pricing is to push harder on the biosimilar comparison. Right now, the ability to really put a common price kind of comparison between the original product and the biosimilars is limited because they will sit in separate codes. And so a reference price approach that puts the original manufactured product and the biosimilars into one code will force the issue further on price competition between those products. I think finding other categories of drugs where that will work will be more challenging. Partly clinically, finding situations where there's a good clinical consensus that two drugs are sufficiently similar to really throw them into a reference pricing together. And then politically, even if there's good evidence, and we've seen it in some international settings where the cases are made, and certainly in some people have made the argument here, but politically, this is something that's going to be very hard for CMS to push through, and we saw this with the legal challenges over least costly alternatives historically. And so, you know, to me, one of the best opportunities to sort of try out the reference pricing approach is specifically within the biosimilar kind of category.
So let me look to the clinicians actually. Reference pricing outside of biosimilars. What are your thoughts?
I've never been involved with it yet, so it's hard for me to say if it would be worthwhile or not. I think that's got to be studied, and I have to be honest with you, I'm not the expert in that area, so I think I would probably defer on a thumbs up or thumbs down until we actually, at least I get more knowledge on it.
Yeah, it's you know, the theory is, you know, that in the context where, you know, two drugs are clinically identical or clinically indistinguishable, there's a possibility of competition, and that manufacturers will compete for market share like every other marketplace, unlike drugs, by lowering market price, and they will pull down the other drug price. And Jack mentions this issue of putting biosimilars with the branded product, something we would call a consolidated payment code approach, you know, as an opportunity for that. But let's, you know, before, there's no one up here who's hysterical around this issue, but like, you know, let me level set. So Jack mentioned least costly alternative. Medicare's idea, and there's probably people here from the agency, so no derision intended. Medicare's big ideas around this are things like, let's pay the same for levalbuterol as albuterol. When a branded product that, I don't know the number off the top of my head, cost 50x the cost of albuterol. The only difference there is that half of albuterol is inert. I'm a pulmonologist, I actually can speak with authority about this issue, right? And they can't do it, right? So we're talking about essentially in fully interchangeable drugs, the second of which was approved by comparison to the first one. Another example, again, a pulmonary drug, two generic drugs mixed together. You can buy them at a pharmacy together for 80 cents, put together and made into a branded product that costs $30 or $40. Medicare tried to pay for the two components in the canister as if they were generic, and they couldn't. And so this is our adventurous Medicare program plunging in to reference pricing, and they can't even get that far. So I am relatively unconcerned that the agency will go deep into this area and be like, oh, these two things that are completely different, you know, radiotherapy compared to neoadjuvant therapy for rectal cancers, those are equivalent, we're going to reference price them. I think they're just, it would be nice if the agency had the ability, for example, pay for the same drug at the same rate, whether or not it's combined with some other drug.
Right. So to what extent does the proposed rule then provide the level of specificity that the public needs to be able to respond in a meaningful way to provide CMS guidance with what those examples are?
Yeah, I think, it is the public that needs to step forward and say, here's the places we feel comfortable, here are the places we don't. It's clearly a crayon drawing of phase 2 right now, right? So we need to provide that level of specificity. A drug, Braxane came up. I don't mean to pick on that drug, but, that came up as an example where ASCO, I think, I don't want to speak for ASCO either, but, there's pretty clear evidence from randomized trials that those drugs would be interchangeable with the generic, at least in the breast cancer setting.
But even in the context of biosimilars, where CMS has taken baby steps to go in this direction by finalizing a policy that would put subsequent biosimilars of the same reference in the same code, that forgets that the biosimilars are similar. They're not tested relative to each other. They may have different indications than the reference product that they're approved for, and they haven't been shown to be interchangeable, meaning that they're going to have the same clinical effect for the patient if you were to bounce back and forth between, say, the reference, the biosimilar, and another biosimilar. You have none of that data, but CMS is jumping ahead to draw a conclusion that data doesn't yet even support or suggest that it makes sense to go in that direction. So I kind of take reference pricing as a proposal in phase 2 off the table because it's not actually something that is relevant to the conversation. I think that the direction that contracting and all of the alternative payment models and these types of things are going is really more towards outcomes-based, risk-based, indication-based, all of those types of proposals that really do have an opportunity with some thoughtful discussion. And there's a way to do that in a responsible way for patients as well.
So just to be clear, you're opposed to reference pricing because of the logistical challenge, or because of the difficulty in
It's not a market-based proposal. We're opposed to it because we think that there are better marketplace solutions that would actually balance patient access and the need for continued innovation, and that is not one.
So to what extent then are indication-based pricing and risk-sharing agreements market-based proposals in your mind?
Those are based on the contractual arrangements between the manufacturers and whoever the other side party is, where you can demonstrate that, say, one indication may be more valuable than another indication, and you can contract against that and protect against the type of arbitrage opportunities that might present themselves as a result and those sorts of things, or even for a patient on try before you buy, so that if you can't specify which patients are going to respond, you have the ability to make sure that only the responders do end up paying for the product. And so those are things that are very creative, novel things that we can do that that manufacturers are interested in moving towards, and that maintains kind of the private contractual abilities of manufacturers, and so those are market-based, yeah.
So Peter, I see you nodding your head. Let me get your response to...
You can't see the bewilderment from sitting behind me. On the reference, right, so this issue about biosimilars, obviously these are, Laurel's comments are, oft repeated, but let's be clear here. For one thing, the biosimilars, are being manufactured with newer techniques than the original originator drugs. And the standard against this issue about indications is one that we don't hold branded biologics to, right? So I as a doctor can use a branded biologic off-label, but the bio industry doesn't want a generic or a biosimilar to be used off-label because it doesn't meet a standard of evidence that the innovator compound hasn't met.
We're certainly not in a position of promoting that off-label use.
I don't want us to go...
to do that.
I don't want us to go off on the tangent talking about biosimilars, but...
All right, no, but I mean, these are the kind of ready opportunities. I mean, you could make the same argument. In fact, the manufacturer did that. Levalbuterol is not the same as albuterol, even though they earned their way on the market by proving they were the same as albuterol, right? So you could always get wound up in these, and those actually are market-based solutions in the classic sense, competition between things that are interchangeable around price. So it has this artifact of being through the Part B ASP system, but it's still the same general principle. On indication-specific pricing, I'm really pleased to see it in the proposal. It's something I imported it from Europe, but that's a secret because we're not allowed to do European things in the US. But it is the idea that a certain drug with multiple indications, although it works in each indication, has different value because costs, for example, the same for adjuvant as metastatic treatment with Herceptin, but the benefit to the patient who receives the drug is many-fold different, right? And so the idea is that the prices should travel with those indications, and there are ways, as Laurel mentioned, to avoid, Laurel called it arbitrage, I'd call it fraud, but whatever, to avoid diversion of drugs for one indication when they should actually have a different one. And so I think those sorts of value-based approaches have a lot of potential. And they're market-based in the sense that it's inherently logical to pay a price based on how well a product works.
So would you argue that reference pricing is a market-based solution then?
Well, to the extent that it leads to competition between different manufacturers making interchangeable products, which is exactly what goes on in every other market, of course it's a market-based solution. It has this artifact that it has to go through the ASP, which means it has this blended price feature, but that's actually not that dissimilar with what goes on with competition other places.
Jack, can I get your feedback on that?
Yeah, I mean, I think reference-based pricing is a market-based solution. It is just as Peter said, it's about trying to allow those two products to truly compete in price rather than have this artifact of sort of saying they have to stay in separate categories in an ASP pricing system. And yes, we've got to move in terms of things like the FDA has to establish its standards for interchangeability, and so that we can make those kinds of judgments. I think the point that the albuterol case sort of emphasizes is that this is going to run into challenges, and so politically this is going to continue to be hard to do. That doesn't say we shouldn't try to include it and find the right opportunities. I think that the 2 points across all of these things is each of these are going to have a lot of political challenges, not in the concept, which is what we were arguing about more in the first panel, is whether politically it was a good approach. Here the politics is going to be, okay, you take the approach, and then somebody goes to court or somebody goes to Congress and says, oh, but don't do it on this case. And that's the kind of thing that we ran into on the least costly alternative, the albuterol, and several of the other kinds of cases. It just couldn't happen because of the specific politics that enters in around those issues. You know, I think that the other part of this is that any of these categories in this list are going to be drug class specific. There are many drugs where indication-specific pricing just is irrelevant because there's only really one indication that's relevant to that drug. There's others where it's highly relevant. And so I think, you know, again, both a technical challenge and then sort of what do you do in terms of implementing this through the demonstration is how to identify the drugs that for which this particular approach may be suitable, and then figure out how to again, deal with sort of the, you know, do what the demonstration is about, lift some of the barriers to trying these things and doing it in the right way. And you know, if there are other barriers that having to do with the best price and thing, you know, thinking about how we should get about addressing some of those as well.
And Jack raises an important point that there's not a, I hate to use it, but one-size-fits-all approach to these different arrangements, that it will not work for all drugs, for all classes, and that you have to maintain that flexibility to be able to contract and work with the agency, with provider groups, and kind of design what is most efficient for the system.
So let me piggyback off of that, Stacy. When we think about the process by which we would actually formulate these pricing policies based on value, what are the key principles that you think Medicare should think about?
Yeah, well, I think, you know, CMS in the proposal does say that these tools will be for a limited number of Part B medications, and they do outline, you know, a process through which they will solicit public input on which specific prescription drugs these tools apply to. I think, you know, from our perspective, that's important. This needs to be a transparent process. It needs to be an evidence-based process. And, you know, I come back to something that Dr. Conway said. He indicated that stakeholders will be engaged in this demonstration at every step of the way. And for us, making sure that beneficiaries themselves and consumer advocates are continuously engaged is critically important. So I think a real emphasis on transparency and a real emphasis on an evidence-based process is what will ultimately make this work or not work for beneficiaries and for other stakeholders as well.
So that's, you remind me of what I wanted to hit on. It's the issue of evidence then. So when if we were to make these policies, if CMS was to create policies based on clinical evidence, these are studies that capture the effect of drugs on a population average. There may or may not be studies that drill down at specific subpopulations, but to Laurel's point, there will be this difference in effect from one patient to another. So how exactly do we figure this out then and capture that nuance in these pricing policies?
So if I were to think about that, I think one of the challenges as I've worked with the ASCO model is if you have a well-designed randomized clinical trial, you can make those comparisons, but it's hard to go from this trial over here to this trial over here to compare 3 drugs when we have 2 here and 2 here. And I think that's where we have to allow our knowledge systems to develop, hopefully very quickly in big data, where we can start to do these comparisons of drugs that have not been actually tested head-to-head in clinical trials. So I think that's going to be one of the real challenges here, is what is the evidence we have to be able to come up with these comparative values. And again, I think we're in the process of trying to put together these big data systems to be able to do that, and I think that'll be really important information as we move forward on this. But that is a challenge right now, is being able to actually do those comparisons between drugs, comparative analysis, basically.
Yeah, and just since Steve didn't plug it, CancerLink is
Yes,
what you're talking about,
absolutely.
right? There's other large data sets out there as well, and that is important. But again, back to the earlier panel, the difference between the static case, the current case, and the dynamic case is important to emphasize. If it were the case that pricing started to travel actually with the value of therapies, there would be incentives throughout the system to better characterize it and to subcategorize it in the ways you've talked about. But right now we don't have those incentives in place, and prices are fixed for the drug, not its use. And subgroups are important, of course, and there's a lot going on in the manufacturer and innovator side looking at subgroups as well. But we shouldn't assume because today we don't have granularity that if we create a system that requires that granularity, or that manufacturers will benefit from the granularity, that it won't evolve. We are actually sitting on piles of data in many places which could start to highlight this. And in terms of cross-study comparison, the term of art that Steve's talking about, if manufacturers were going to be compared across studies on endpoints, they would tactically select similar endpoints to other studies, as opposed to what they do currently, which is tactically selecting disparate endpoints to prevent cross-study comparison.
So, or do you want to respond to that?
So something that Stacy said earlier, I think, is relevant here, both in the context of phase 2 and then generally in our approach to evidence-based care. That knowledge is important, but it needs to be used not in a way to direct care, but to inform care and to maintain that it's the patient and the provider who are making those decisions, and that it's not the system that is directing the utilization of one product over another, one intervention over another, and making sure that those analyses are holistic enough to take into account how all of those pieces work.
Right.
Yeah, I just wanted to build on this. I mean, we don't have enough evidence in many cases about the comparative effectiveness of different products. And I think part of the notion, like what Peter said, is create some incentives to build the right kind of comparisons. I mean, we've got efforts out there to try to do more of it. There are things moving in this direction. And of course, we also restrict ourselves in many settings from looking at comparative cost effectiveness. We have to limit in many of the government-financed research efforts and CORI and so forth to just comparative effectiveness without sort of letting the cost piece enter into it. And that's really a core of what we're doing, is thinking not just about the relative clinical advantage, but the relative clinical advantage with price factored into it.
So let me move on to sort of getting people's input on the prioritization of the different value-based pricing strategies. If you were to make a recommendation on what CMS should prioritize and what it should prioritize less, help me get a sense of what your thinking is. So it's risk-sharing agreements, VBID, it's reference pricing, and indication-based pricing. What's at the top of your list? What's at the bottom of your list? Let me start with Peter.
You left the top of my list out, competitive acquisition.
There you go.
Right, so which was in phase 2. And let me spend a second explaining what it is. It comes from the MMA. MMA keeps coming up, 2003 law, which allowed essentially a peeling back of the distribution system for drugs, Part B drugs. So instead of doctors and hospitals doing what's called buy and bill, the entire thing we've been talking about today, instead there'd be white bagging, a system where if you need a drug, a Abraxane or something, just to throw out a drug, you, instead of purchasing that drug as a doctor or hospital, you essentially call up FedEx, and an intermediary, a large intermediary, drop ships it to you. When you obtain the drug, it's not yours as a doctor, it's the patient's, and the patient comes, gets the treatment. And all the billing, reconciliation, coinsurance happens at that large intermediary. So you become essentially a courier of the drug as a doctor or hospital rather than the owner able to mark it up. And the system was tried. I was part of the implementation, so I take full discredit for its failure. But what the idea sort of on the table, and CMS points at it, is, why don't we look at this in a tactical way around the most important drugs? And again, this is the last plug of this morning's report from our group, which is at drugabacus.org, where we look at the concentration of spending in Part B and how, if you will, the story is really about the top 10 drugs, at least in oncology. And that's true really more broadly across Part B. Top 10 drugs, 15% of the encounters, 75+% of the spending. It's these major drugs we've talked about all day long. If we peeled those back, if we got rid of buy and bill for those drugs, these are the benefits. One, the markup, which is also in our report, by the way, is about 48 cents on the dollar for all these drugs, in terms of what is paid to doctors, hospitals, and 340B hospitals have the largest. And you would sort of reclaim that money. It would come out of the pockets of doctors and hospitals. That would have to be reconciled around some sort of managing fee. But it would also clear up these distorting incentives of different profits available to hospitals that have more negotiating leverage than doctors. So it would actually help doctors. It would help small practices because what's driving their economics is the high cost of these agents. And they would essentially now be out of the buy and bill system. They wouldn't have to buy it and reuse it. And then the last thing on indication-specific pricing, if you got a responsible intermediary, those drugs could travel with their indication and thus with their price. And this would, again, Laurel called it, I don't know what you called it, diversion or some polite term, arbitrage. It would reduce or eliminate arbitrage because the drug would be married to a patient with a particular indication. So we could sort of manage that. But the way for CMS to think about this, and it enables all these other things, is, first of all, this entire conversation is really about 10 drugs, not about the 100 or 150 in Part B, just in terms of the math. And the next is, these end user markups are the entire challenge with this incentive thing that we talked about with phase 1, which I know we're not allowed to talk about on this panel, so I won't. But that peels back all of that.
So I don't think I have one priority over the other, because I think as we were just talking here, I think the details of how these are going to work out, I think, have to be looked at. And again, from my perspective, from a practice, whatever works out best to allow us to give the right drug at the right time and keep the doors open and pay for all the services we have to pay for in a practice to take care of these complex patients. I think any one that would work certainly needs to be looked at carefully. So I think the key point is getting down to the details on it.
I sort of already answered it, but off the table for us is reference pricing, but there's so much opportunity in value-based payment and VBID and APMs. I think there's more than enough to go around in terms of a productive discussion on those types of topics that we're certainly interested in having a much more thoughtful approach with CMS on.
Yeah, and I too have difficulty sort of ranking them. It's more, I think, if there's interest either as a policy community or a research community in sort of saying how well will each of these work, then the key is sort of matching the drug classes and the specific examples of drugs to the different pieces and trying, this set of drugs under reference pricing, this set under indication-based, this set under outcomes-based risk sharing or whatever, and another set under VBID, and then worrying about the potential problems, adverse consequences that may arise under any of these, and making sure you've got an adequate way to protect yourself from, manipulation of the indication-specific pricing, as we've talked about a little bit. I think with the competitive acquisition, it's something that was so unsuccessful in the first time. I think it's kind of hard to get that back into the conversation, and I think maybe it does belong in there because clearly the buy and bill is, and Peter, you said this well, is sort of creating a lot of the other issues that we're trying to deal with. And there are a variety of ideas. You talked about some of them, sort of how you could do this differently in a refashioned version, whether there's some potential use for stock replacement elements. I mean, I know that one of the issues on oncology is, making changes in the dosing that you're going to provide right there 15 minutes before the infusion starts. And so you can't wait for FedEx. That's going to require the patient to come back a second day. Now, that may not be all of the time by any means, But there are potentials with stock replacement where you draw that out of your existing stock and then the FedEx shipment arrives the next day to replace it. And so again, if we think that's got potential to go in, I think we can look at a variety of ways. And then we also have to, I think, if we're thinking about that approach, think about what is it that will make it feel more acceptable. Because I think what we saw, and again, some of the interviews I did 10 years ago was just sort of a gut reaction from a lot of medical practices saying, you know, I've kind of got this figured out. Don't mess around with something that seems like it's very artificial and hard to operate. Figuring out what are the incentives and what are the adjustments to make it more palatable to practices to say, yeah, this the way you've now designed it would actually potentially work for me. And many of the practices would certainly be glad to not carry the inventory costs of maintaining the large sort of inventories that they do today.
One data point on CAP, just to point out, it had a whole host of issues as to why it didn't work out. But one of the things that it's key to keep in mind is that it was reimbursed at more than ASP plus 6. MedPAC commissioner or staff has pointed that out. So as it relates to phase 1, that program didn't work, and they were getting reimbursed at above ASP plus 6, higher than what we're talking about in phase 1.
Right, and so figuring out ways to work on the pricing side and you know, what's the power that the vendor has. I mean, people have talked about things like vendor-driven formularies and various other kinds of things to allow them to negotiate. You know, again, anytime you're going to have a negotiation work for price, there's got to be something to negotiate with. It's a preferred position. Obviously, it works better when there are competing products. And so the vendor is going to need those same kinds of tools or some set of tools to be able to get good prices. They can't just say, oh, I'm now the vendor, you're going to give me a good price. It's not that simple.
So can I just one thought on that, because I think it's an interesting point. You know, we're going to find out here shortly how many practices in the United States have voluntarily gone into this oncology care model. Perhaps that should be the thought process for these other new things, is figure them out, show the details, and allow practices to voluntarily go into the program, just like we've done with the OCM. That may be part of the problem, the solution to this idea that, gee, we're going to have zip code areas and maybe they'll send the patient outside of it. If the practice as a whole says, I'm willing to try out one of these new models, perhaps that might be a way to get around some of the problems we've discussed with today.
And of course, the challenge from a research point of view.
Let me go to Stacy to finish up that, but I want to come back to you, Steve.
Well, I think the value-based tool that we would probably prioritize would be the value-based insurance design and the lowering of beneficiary co-insurance. But I think that has to be coupled with 3 things. One, as I mentioned before, there does need to be a transparent process for determining which prescription drugs are high value and receive that lower cost sharing and which ones are not. 2, there need to be the clinical decision support tools that are envisioned in the proposal. Because I think that, you know, providers need to be appropriately educated on which prescription drugs have been pegged as high value. And then 3, I think the pre-appeals exceptions process that CMS outlines in the model needs to allow for beneficiaries to appeal for lower cost sharing if they do have a clinical need for a medication which has not been determined to be high value. I don't think it's clear in the proposed rule that that will be the case. But we think, in general, the pre-appeals process is an important consumer protection. We want to make sure that it extends to that value-based insurance design component of the model.
So I guess the last thought I want to close that on, there has been a lot of talk about how the proposed payment model would interact with OCM. So it sounded like there were a couple comments that were incoming in this regard. Jack, do you want to go ahead?
Yeah, I don't know all the ins and outs of the OCM model, certainly as well as some of my colleagues do. But I mean, I think I was just going to comment briefly on the sort of voluntary versus random assignment. I mean, obviously, from a research point of view, random assignment allows you some ability to draw conclusions that voluntary participation doesn't. We've had, you know, a challenging history with demonstrations for many years, long before CMMI, where you do something, one organization does it, boy, it looks really good, we feel like we have good results, but it's sort of compared to what? And then you go to replicate it, and maybe it doesn't work as well. And I think that's just the challenge. I'm not saying that rules that out as an approach. And obviously, it's the approach being used in this particular one. But that's that's one of the factors I think that you just have to enter into. I mean, I think, to some degree, it's like, let's try a lot of things. We feel like there are some big problems to be fixed. Let's try some different things across the system and see what works. Let's make sure we try them in a way that we'll actually know in the end whether they do work.
Peter, did you have thoughts on that?
Yeah, not a lot. I don't feel steeply or deeply educated in the OCM either, but it is fundamentally a gain share model. So if there's a pricing component which has to do with the add-on profit that shifts to lower cost drugs, that's sort of a double bonus for the OCMs. Of course, that may not go that direction. We don't know if it will shift behavior, but I think that's one way to think about it. The only other thing, quickly on CAP, it's true that the original program had, 120, 140 drugs in it, including, I think, bags of normal saline. So when you had super cheap drugs, or things that were virtually not drugs, of course the margins were hard to maintain. And under the new phase 1 pilot, half of drugs will get more than ASP plus 6 because the flat fee will be much larger, such as bags of normal saline, right, or Decadron. So the steroid. So the idea, what I floated, was not reinvigorating CAP, was reconfiguring it around, and I'm going to throw out a number, the top 10 drugs, which are super expensive. And so, a dose of Yervoy is probably $20,000. That's going to be able to be moved for less than $20,000 plus 6%, right? The intermediaries in the drug distribution chain are probably making 100 to 110 basis points on these drugs. That's where I'm talking about setting up this distribution only for these expensive drugs. And it solves all these other challenges, I think, or at least it gives us a way forward.
Great.
You mean to comment on the OCM? Yeah, so I think practices that choose to go into the OCM should be exempted from this whole thing. And there's several reasons why. The OCM has a lot of moving parts in it other than just drugs to try to get higher value at lower cost. And drugs will be looked at in that model in terms of the expenditure by the practice over time. And so I think there's going to be too many hypotheses at once trying to be tested there, and then the practices that are bold enough to try the OCM model, I think you just should leave them out of this one, because there's a lot of things we're testing in there that really the oncology medical home is what we're testing there. So I would leave that out of the drug part of this thing.
So with that, I think we're running out of time. So I'd appreciate it if everybody could join me in thanking our great panel, welcoming, end the day, opposite of the spectrum.
Goodbye.
Thank you.
So I'll just take a moment to wrap us up and add my thanks to Chuck's for a really good, robust discussion today. I mean, probably as everyone knows, some of the letters and comments and discussion around this proposal that have been out there in public have been pretty vehement, and I think we've here had a really constructive, creative discussion, and I think it was very much what we'd hoped for, and thank our panelists and credit them for that. As I think about what we heard, I think there are two potential extreme scenarios here. One is that this proposed experiment results in a mitigation of rising drug costs. Patients continue to get the drugs that they need when they need them, and that practices really aren't all that much affected. Another scenario at the other extreme is that this is disastrous for a lot of practices. Patients don't get access to the drugs they need. It drives big changes in the healthcare delivery system for not much gain. Figuring out, and as Peter Bach, we don't know the answer. We don't know which of these is realistic, and as Peter said, that's why we do experiments. It seems to me that as CMS decides what to do next on this experiment, that it may be possible to close in on some of these questions, and there's a lot that is not in the public domain about the spread around ASP, and obviously whatever the margin is, whatever the percent of the population or the practices are underwater, depends in part on how tightly clustered around ASP they are, and to my knowledge there's not much of that in public. It also depends, and we focus on the reduction in revenue from high-end drugs, but of course the revenue goes up on low-end drugs, and the impact on practices depends on the distribution across all of the drugs they administer. And that's another place where it does seem to me that in advance of this experiment, it will be possible to get, if not truth, at least to a much closer to a model of predicting what kind of outcomes this will have. Certainly people made the point that there are big changes afoot in how we reimburse healthcare and how we look at quality and value. And maybe drugs is, doing Part B drug reimbursement is just one more piece of that, or maybe it's a sideshow to the bigger show. But certainly the point has been made that this is not the first time that changes to the reimbursement system have been made in an attempt to create the right kind of playing field. And we had a very robust discussion about the experimental design here, with both some real concerns expressed about the potential impact on patients, but also I think a lot of excitement about making a policy change in the environment where we really would have a control group and the ability to assess impact in a prospective way, which we and controlled way, which we don't always do. Obviously, a lot more thinking still to come on what is it CMS will look at to assess not just the impact on cost, but the impact on all of those other things we talked about. In terms of phase 2, I think we had a very good discussion about what are some of the things that might be tried here and which ones should be on the table and which ones are promising. Obviously still a lot to be figured out there, but I think one of the things that we heard from a number of panelists is if you start to kind of partition it and focus down and choose smaller sets of drugs or choose certain indications, that one may become a lot more manageable. Again, a robust discussion about who's in. I think there was, I don't know if it was consensus, but I think a number of people said pretty clearly OCM is enough of an experiment, take that out. The question of do you randomize or do you opt into the experiment, I think is a big one, and we heard strong arguments on both sides. Those are at least some of the things I heard today, and CMS was here and listening and has expressed their strong desire for people to continue to engage and make very concrete suggestions. And then the last theme that I think Stacy made most strongly, but I think everyone would agree with, is the need for all the stakeholders to be involved and for this to move forward in an open and transparent way so people really understand what we're doing and why. And I hope that today's discussion was one piece of that. So thank you. Thank the panelists again. I'd like to thank Chuck Shee, Emily Reese from our specialty drugs team, also Sarah Dupre and Danita Moses, and a whole bunch of other staff at Pew who worked hard to put this together. Thank you. Chuck reminds me to mention by name Aaron Davis and Kevin Kelly from our communications team who worked very hard to put this together.